is a very important topic. I think it has affected, the pathology is quite rampant, and so it's important for us to know how to deal with it and also manage our patients effectively. I think this will also be a very good session for the residents to pick up the silent points in stone management. And as we go along, we'll have a good discussion. My only plea is that please don't doze off. I'm sure we've had a heavy lunch, but try to keep awake, and we'll encourage questions and answers, discussions. I think that will be the way to go. I think without wasting any time, I would tell my colleague to welcome the first presenter. Thank you.
Good afternoon once more. Our first presenter is Dr. Mokua, and Dr. Mokua will give a presentation on factors influencing outcomes of stone management during ureteroscopy and laser lithotripsy at KNH. Welcome, Dr. Mokua.
Good afternoon. I would like to start by thanking the organizing committee for giving me the opportunity to present this study. It's actually an ongoing study from last year, August. So I'll be presenting the preliminary results. And it's usually very difficult to present just straight after lunch, so I'll try and be brief. So the title of this study is the outcomes of ureteric stone management during ureteroscopy and laser lithotripsy in Nairobi. We're going to go through just a brief outline, introduction, bit of literature review, or the methodology for this study, the findings as they are now, and the conclusion. Stone surgery has been, as has been introduced by session chair, it's an increasing problem in our country, and that is compounded by a lack of endourology facilities outside Nairobi. That's why actually this study is centered in Nairobi. So it has been increasing. So a study done by Prof. Mungai in 2010, they actually noted that the numbers have been rising as opposed to the previously thought to be rare. And this is due to increased obesity, diabetes, and the westernization of diet. And the management of stones has changed drastically over the last 30 years, such that currently we have less than 10% of patients managed by open means, open surgery. And worldwide, it peaks in the third and fourth decade of life, and the ratio of male to female is still a male predominance of 3:1. The most common laser modality used for our setup, we use the holmium YAG laser, which is safe and has good stone fragmentation regardless of the stone hardness. And in 2002, so far, detected a complication rate of less than 1% with a stone clearance of more than 97% with minimal complications, without even the need of ureteral stent placement after ureteroscopy. But you'll find from this study that the practice is to put a stent after URS and laser lithotripsy. So the issue, as I just alluded, is whether you need to put a stent postoperatively, even in cases of uncomplicated laser ureteroscopy. And in such cases, these are patients who you have left minimal residual fragments. You have less. These are patients who are not pregnant, patients who didn't have a pre-existing UTI, patients whom you didn't have a ureteric trauma or even minimal bleeding. But routinely, patients, the urologists in our practice, we still put ureteric stents because we want to prevent edema and the pain, and also trying to, you are anticipating that there might be ureteral stricture, and even to prevent, to aid in stone passage, the fragment passage. So as I had said earlier, it's an ongoing prospective study. The study sites are KNH, Coptic Mission Hospital, and Upper Hill Medical Center. At the moment, we have had 48 patients, and it was an administered questionnaire where we have the patient demographics, the pre-op findings, post-op findings, and post-op complications. As generally, we know that it's been documented for ureteric stones. The most common complications are going to arise when you have an impacted stone. The location, site location, if it's proximal, and if there is a long operation time where you have multiple instrumentation or back and forth instrumentation. So the gender, in terms of the numbers, out of the 48, 33 of them are male, and 15 are female. So as you can see, the ratio this time is 2:1, but it's still too early. But it can be clear that the female population is having more of this problem lately. And the age range for this study is from the age of 20 to 70. And the mean was 36 with the mode of 33 years old. So we're having a younger population of patients suffering from this. So in terms of the stone characteristics, laterality, most of these patients will also have concomitant renal stones. And as in keeping with literature, most of it are right-sided, not yet known why, but in terms of laterality, you have more of the stones on the right. Bilateral stones, which shows a stone burden, it's around 22%, which is significant. And in terms of stone location, for these patients, most of them are in the distal third of the ureter. So in terms of this study, we divided them into less than 10 millimeters and more than 10 millimeters. In terms of stone free rate is 68% if they are less than 10 millimeters. And for this stone free rate, we're actually using a KUB ultrasound, KUB imaging modality. And we know that if we were to do a CT scan, the stone free rate will probably become much lower than that, but it's good to report that that's the stone free rate. In terms of digestate placement for stones less than 10 millimeters, it is actually around 85%. In terms of those stones that are more than 10%, the stone free rate now decreases significantly to 43%, and those will actually require at least more than one procedure for you to have a stone free rate. So it's important that when you are going to do the ureteric stone management, to inform the patient that we may actually need more than one procedure. Otherwise, they won't understand why you are going back and forth. So in terms of complication, the most common is stent symptoms, and then there is ureteric mucosal damage, bleeding, UTI, and stent migration. Maybe because sometimes you don't have the fluoroscopy in terms of stent placement. Success rate, I also tried to compare the consultant-led procedure and the resident. And obviously, the consultant with experience, the stone-free rate is much higher, as depicted there. And sometimes also because for proximal stones, sometimes the instruments are lacking for flexible ureteroscopy. So sometimes you are just forced to put on a stent. And then, interestingly, we have around, out of the 48, 12 patients were scheduled for surgery, but 5 of them already had. By the time you're going to do your RS, they already had the stone had passed. So sometimes it's good to one is the timing for patients or medical expulsive therapy to do imaging modality, and you don't want to expose these patients to a lot of radiation. So the conclusion from this study, from the preliminary findings, is that uncomplicated ureteroscopy for distal ureteric calculi without intraoperative ureteral dilatation can safely be performed without placement of ureteral stents. And this is backed up by 2 random control studies. One was in 2013 and the latest in 2020 that show that you don't need to put a stent after, especially for patients who have distal ureteric stones, which in this case it was uncomplicated. Because with the stents, you know that you are going to have a second operation. These are patients who are going to have dysuria, are going to have stent-related complications and even pain, which can also reduce the quality of life. And as you had seen from the results, this is increasing. And so the limitation of the study is that we have the follow-up of these patients was not standard, as I showed, and the basket extraction was not available in all the data collection centers. But with time, when you have bigger numbers, we'll be able to have a more conclusion findings from this study. Thank you.
Thank you for keeping time. I think, the next presenter is Dr. Salman Obi. He's going to tell us about management of recurrent urinary lithiasis. I think this is a big challenge. I think most of us who are in practice, you'll agree with me that there are patients who would come literally after every 2-3 years with a stone. And this actually poses quite a big challenge. So I think it's an important topic that we deliberate on it and see how best we can help our patients in management. Okay. You're welcome, Salman.
Good afternoon, everyone. My name is Dr. Omar bin Salman, and I'm a fourth year M.Med Urology in the University of Nairobi. I'll try to simplify the presentation without involving the theories and controversies in this topic, and to know the medical treatment protocols for different types of stones. The lifetime risk of stone formation is estimated at 5 to 10%, with a recurrence rate after formation of initial stone is 50% at 5 years and 80 to 90% at 10 years. And both EAU and AUA has shown level 1 evidence that kidney stones are preventable. So any stone former who comes to you, you have to categorize them into either a low-risk patient or a high-risk patient. And every patient after passage of stone should undergo stone analysis using X-ray diffraction machine or an infrared spectroscopy. This will try to assess the geometry and architecture of the stone, and a basic stone analysis. The basic stone analysis involves from a medical history, that is, were there previous stone events or any family history, history of any medications and the diet. Then you go to lab works involving like UECs, which will give you the rough idea about the kidney functions, the serum calcium, serum uric acid. Then you move to urine analysis like either routine or dipstick or microscopic culture and sensitivity. And eventually you do a pH measurement for every urine, a minimum of 4 measurements. Finally, you do your diagnostics, that is ultrasound and CT scan. Ultrasound and CT scan will give you the anatomical abnormalities of the genitourinary system, and specifically the CT scan will give you the Hounsfield unit, and this will give you a rough idea about which type of stone you're dealing with. So for high-risk stone formers, general factors like early onset of urolithiasis, familial stone, presence of bruchide-containing stone, disease associated with stone formation like hyperparathyroidism, genetics play a role, drug associated with stone formation, and anatomical abnormality associated with stone formation. So Sir William Osler said, one of the first duties of the physician is to educate the masses not to take medicine. So this comes to the general preventive measures. Any patient, for either low-risk stone former or high-risk stone former, you have to give them general preventive measures. And it doesn't come into surprise that the first thing we give is fluids. Fluids, that is water, approximately 3 liters to 3.5 liters per day. The aim is to produce a lot of urine to dissolve the supersaturations. Next is diet, that is vegetable and fruits, especially the ones rich in citrate. We are in era of corona where everyone is taking ascorbic, that is vitamin C. Vitamin C has been shown to be a precursor of oxalate, so any stone former advise them to limit excessive use of vitamin C. Next is salt, preferably not to exceed 3 to 5 grams per day. what salt has been shown is it increases the excretion of calcium and causes monosodium urate, which is a promoter of stone growth. Animal proteins, like not to exceed approximately 1 gram per kg of body weight, animal protein has been shown to cause hypocitraturia, hyperuricosuriahypoxaluria, and it decreases the urine pH. And finally, advise your patient to be doing a lot of exercises. So for any high stone formers, before you do any metabolic workup, you have to find out how motivated the patients are to do these analytical and therapeutical procedures. So EAU guidelines recommend 2 consecutive 24-hour urine sample. This sample should be taken on a normal day. Experience has been shown that it's normally taken on a weekend. The collected urine should be stored at least less than 8 degrees Celsius so that to prevent spontaneous crystallization. The patient should be stone free a minimum of 20 days from the time of stone evacuation to the time of metabolic workups. And finally, once the patient has been administered pharmacological therapy, the patient is followed up for 8 to 12 weeks to see if there is any changes in the post-pharmacological therapy. If not, the dose is adjusted. So the 24-hour urine should answer the following. What forms the stone? Are stone inhibitors lacking? And finally, are there stone promoters, although without becoming part of the stone itself? So as urologists, we'll ask ourselves, is there a need of doing this sophisticated test? Keeping in mind that the first thing is we have minimal invasive stone management. Second, it is more practical to treat than doing these complex evaluations. And finally, it is debatable evidence of impact on recurrence. Also to add, we know that the calcium oxalate is the most common stone. We might say, we might predict that the result will come as a calcium oxalate, but the analysis will pay if it comes as an calcium stone or a bruchide, for example, containing stone. So this rationale may be applicable for first-time stone formers with unremarkable serum chemistry, normal urinalysis, no family history, and no underlying medical condition associated with stones. So I tried to make this algorithm to try to simplify. So you either have a calcium stone or an calcium stone. A calcium, you either have normocalciuria or hypercalciuria. In normocalciuria, either you have increased promoters, that is hyperuricosuriasis, or decreased inhibitors, hypocitraturia, or in excessive solutes like hypoxaluria. In case of hypercalciuria, you do the serum calcium. If serum calcium is high, you should suspect hyperparathyroidism. If serum calcium is normal, according to Clayman, whatever the diagnosis is, treat the patient with thiazide. And next you have is non-calcium stones. So according to EAU guidelines, pharmacological treatment should hold stone formation, should be easy to administer, and should have no side effects. We go back to the stone. In case of you have normocalciuria with hyperuricosuriasis, alkalinize the urine and then give allopurinols. Remember, all these patients have to be given general preventive measures. Next is hypocitraturia, you have to replace the citrate. In case of hyperoxaluria, remember they are normocalciuria. So give them calcium. Calcium will bind with the oxalate in the intestine, preventing absorption. And if you are suspecting primary hyperoxaluria, give the patient pyridoxine. Pyridoxine has been shown to decrease production of endogenous oxalates. In case of hypercalciuria with increased serum calcium, if you are suspecting hyperparathyroidism, do parathyroidectomy. In case you have ruled out hyperparathyroidism, cover the patient with thiazide and give L-methionine to adjust the urine to approximately 5.8 to 6.2 pH. In case of serum calcium, as I have said, according to Clayman, thiazide is cover the patient with thiazide. Next is non-calcium stone. Now, in uric acid, alkalinize the urine, give the patient allopurinol, and if you are suspecting ammonium urate stones, cover the patient with antibiotics and adjust the urine pH. In infections, make sure that, be it if there is any residual stone, patients should undergo back to surgery and evacuate everything. Because if you leave a residual stone, this stone will keep recurring. So do surgery, cover the patient with antibiotics, be it long time or short time, and then use urine acidification. Because these patients, the pH mostly is more than 7.2. So you want to acidify the urine. And finally, cysteine, you alkalinize the urine with alkaline citrate and tiopronin. Tiopronin, what it does, it breaks the bonds of cysteine, making it more soluble. If we don't have tiopronin, you can give captopril. So my take-home message is, most common abnormality is hypercalciuria. However, patient will have more than one abnormality. Next is, many fast stone formers may not benefit from metabolic evaluation unless the initial screening put them on high risk. Recurrent stone formers are best treated with metabolic evaluation and direct medical therapy. And finally, both surgical and medical management of urolithiasis rest in the realm of urologists and not nephrologists. Thank you very much.
Thank you very much, Dr. Salman, for keeping time. Our next presenter is Dr. Matu. Sorry for that.
Good afternoon.
Good afternoon.
As you all can see, my name is Dr. Damatu. My name is Dr. Carol Ndiwa. I'm a fifth-year medical urological resident, University of Nairobi. Yeah, so my name is Dr. Carol Ndiwa, a fifth-year M.Med Urology, University of Nairobi. So I'm going to present on nephrolithotomy. The objectives I'm supposed to cover are, when is nephrolithotomy indicated, how and why. So introduction, basically nephrolithotomy is a procedure whereby you make an parenchymal incision on the kidney to extract a stone. Most of the time is indicated for complete stagons. Smith and Boyce in 1968 came up with described a procedure in which by the incision on the kidney was made on relatively a vascular plane of the kidney, what we call the Brodel line. And it is a line that is usually 1 to 2 centimeters posterior on the convex surface of the kidney. Current guidelines indicate or advocate for management of stagons, advocate for Pcnl and shockwave lithotripsy, but state that conventional excision must be considered in exceptional cases, and these are the cases we are going to discuss. So basically this was, I just did a literature review. I searched from PubMed, and I used the word anatrophic nephrolithotomy. And I came up with, I saw 17 articles that I'm going to summarize. There's no local data on anatrophic nephrolithotomy in our country. The last 3 years, we've only done one nephrolithotomy in KNH. And from literature, open surgery still has a role in stone management and constitutes 1 to 5.4% of all stone surgeries. So when is a nephrolithotomy indicated? When you have a high stone burden, and that could make a patient undergo multiple and many auxiliary procedures. In patients with renal malformations like calyceal deformations or infundibular stenosis. In patients who have failed a reasonable number of endourological procedures. is an indication, and in patients who are morbidly obese, because there are challenges to their position and also use of fluoroscopy because of the fat that highlights on x-rays. And patients with skeletal deformities, and in our setup whereby the facility for doing things like Pcnl and Shockwave, and also the expertise is a bit limited. So how is a nephrolithotomy or anatrophic nephrolithotomy done? So I'm going to describe the original procedure that was proposed by Smith. So the patient is usually under GA. You sterile catheterize the patient, you put the patient in kidney position, and you make a flank incision on either the 11th or the 12th rib, usually supracostal. It's a retroperitoneal approach. You identify the ureter and use the ureter to take you to the hilum. When in the hilum, you identify the renal artery and also dissect and identify both the anterior and the posterior segmental arteries. Your interest there will be the posterior segmental artery. I'm sorry about that, injection of methylene blue. You clamp the posterior segmental artery and then you give IV methylene blue. And what this does is the methylene blue goes to the anterior segmental and highlights where the anterior segmental artery supplies the kidney. So to identify the vascular plane is usually visualized by blanching of the blue color on the kidney. After that, you give mannitol 100 milligrams of 20% mannitol. Then you after you blanch, after you identify the blanching caused by the methylene blue, you make an incision on the plane with cautery. Then after that, you clamp the entire renal artery, and after clamping, you cool the kidney using slush for about 10 minutes. Then after 10 minutes, you make the incision on that avascular plane. So that diagram shows where you make the incision, usually around 1 to 2 centimeters on the posterior surface of the kidney, behind the convex surface of the kidney. You make an incision on that plane, avoiding the poles of the kidney. And then basically you lay open the kidney and you extract the stone. After that, after you extract the stone, you repair the calyces using a Vicryl 5-0. When you're repairing, you keep on releasing the artery, the arterial clamp, to see if there's any bleeding for you to achieve hemostasis. Then after that, you do the parenchymal repair. You leave a before you close the calyces, you're supposed to deploy a stent or a nephrostomist tube if indicated. Leave a peritoneal drain, and you do wound closure in layers. So what are the modifications? Because I know people who do anatrophic nephrolithotomy, they don't follow the original description. So modifications have been done. One of the modification is pre-stenting before the nephrostomy, and these are is shown to have better outcomes in terms of ureteric patency. Not clamping the posterior segmental artery to identify the vascular plane, because it's been identified that the border line is almost constant. It's about 1 to 2 centimeters, so there is no need to really give methylene blue and to clamp the posterior segmental artery. And the other modifications is use of robotic and or laparoscopy to do the nephrolithotomy. And these modifications are basically to try to curb the complications that are encountered when you do the original anatrophic nephrolithotomy. So why are we doing this? Why am I doing this presentation? The reason we are doing this presentation, because we all know that we have several patients and many patients with Stargardt calculus, and we have limited skill in terms of Pcnl. So this presentation is basically to encourage all of us to not shy away from doing anatrophic nephrolithotomy because it's safe, and I'm going to discuss that. So in terms of renal injury, when you compare Pcnl and anatrophic nephrolithotomy. Alkolani did a study, and the study had around 1,000 patients, and it did not demonstrate any cause of renal function deterioration after doing nephrolithotomy 3 months with a MAG3. Similarly, El Tabay and Fayad et al. Also did not demonstrate any renal injury or deterioration after anatrophic nephrolithotomy, but they demonstrated that Pcnl in patients with solitary kidney contribute to more renal injury than if you did than the ones who underwent nephrolithotomy. In terms of auxiliary procedures, averagely patients with Stagons, when they undergo Pcnl and Shockwave, averagely they undergo 2 to 3.7 procedures. And in our case, whereby the cost of stone management is high, so these auxiliary procedures increase the cost of stone management, and this one would be a reason why someone would do the nephrolithotomy over Pcnl. In terms of stone clearance, there are 2 prospective studies I came across. One was they were looking at stone-free rates after anatrophic nephrolithotomy at the time of discharge, and they found that anatrophic nephrolithotomy had stone-free rate of 66.7% versus 48% of Pcnl. And the second study was done 2 weeks post the procedure, and the stone clearance was better with anatrophic nephrolithotomy. But still the guidelines state that anatrophic nephrolithotomy has a lower stone-free rate because of 71% versus Pcnl of 76%, because there are other factors that they considered because of the auxiliary procedures that make the Pcnl have better, at the end of the day, has better stone clearance. In terms of post-op complications, of course, the open procedures have more complications in terms of blood loss, length of stay, urine leak, and septicemia. But to minimize these, or to try to curb these complications, that's why now laparoscopy and robotic surgery came in to try to minimize these complications. So my conclusion is the morbidity of a loin incision and a delayed recovery must be weighed against the need for multiple procedures. And when performed by experienced urologists, anatrophic nephrolithotomy yields results that are almost comparable to Pcnl, and adequate training is needed in our setup. Thank you.
Thank you very much, Caroline, for keeping time and also for a good presentation. The next presenter is Dr. Yusuf. Dr. Yusuf is going to tell us about recent advances in percutaneous nephrolithotomy. Welcome, Dr. Yusuf.
Good afternoon, everybody. Really, thank you for much for your kind invitation to me to attend this course for the first time for me in the country. Okay, yeah. Really, I will start today to talk about the updates in Pcnl. All of us know that it is now the standard management for large stone kidney. So my topic will discuss some points about the history of Pcnl, anatomical consideration and steps of Pcnl, and what is the message that we'll take to home. So if we start about history, we found that in 1871, it was the first trial, the first trocar introduced and punctured the kidney. And in late of 60s, we found that the percutaneous nephrostomy becomes more popular, and the dilatation of the nephrostomy tract, it took from several days to several weeks. The first Pcnl done in 1974, and the first research done in 1978 by Smith for 5 cases, and we can see the set which they did the percutaneous nephrolithotomy with it in that time. If we talk about some anatomical consideration, we can find that there is a very important point we have to keep in mind, that when I am thinking to have a puncture, I have to know that the upper calyx is a dangerous point, and also if I think to puncture through the pelvis, it is also a dangerous point, because both of them, they have, as we see here, a lot of vessels and the great vessels in the pelvis, but the safest area is the posterior calyx of the lower pool, because it is nearly free of vessels. So all of us know that nowadays Pcnl is recommended as the therapy for renal stones more than 2 centimeters, and also for a smaller stone if there is some contraindication on unfavorable factors for ESWL. If we'll talk about the positioning of the patient, now we have 2 types of positions, either prone position or supine position. This is now which is known all over the world for positioning of the patient. Every position, of course, has some advantage and some disadvantage. If we'll talk about the prone position, we'll find that the advantage is there is a good area for the puncture. I can reduce the risk of visceral injury. Also, I can do multiple access to the kidney. But you know, if the patient in prone position, there is some difficulties for the anesthetist to control and to monitor the patient. Also, there is a higher radiation dose. If I will talk about the supine position, all the complication of the disadvantage in the prone position will be solved in the supine position, but I will still some disadvantages, like that I cannot access the upper calyx, it will be difficult. I cannot do multiple access for the kidney. Also, there is hypermobility for the kidney. It will make the puncture slightly difficult. So if we see in this diagram, we can see that if I will choose the prone position, I have to do the cystoscopy and the stenting in a position, and I will change the position of the patient to the prone position to continue my procedure. If I will continue, or I will choose the supine position, I can do all the procedure in one position, the supine positions, and for this it is time saving, the supine position. But in the literatures, they compared around 775 patients in some of supine and some in prone position. They didn't find any superiority of any one of them for the stone-free rate or the complication or the morbidity. So the most important here is to do a good job. If I will talk about the puncture, I think all of us know that we have a lot of types to puncture the kidney. The short learning curve is ultrasound puncture. We can use the probe 3.5 to 5 megahertz. The advantage of this procedure that we have a limit radiation, and it is of course lower cost, and I can visualize the surrounding organs, and there is a shorter learning curve. But which is the most famous is to use the fluoroscopy. The fluoroscopy, I have different ways to puncture the kidney, starting by the monopolar axis. Monopolar axis, it depends on the surgeon experience, because they only use one plane of the X-ray, which is the vertical one. But in the biplanar axis, or the pull eyes, I can use two planes to puncture the kidney, the AP and the 30 degree, and it is much easier than the first one. And this is a traditional way, the triangulation technique, to attack the calyx, that I am marking the calyx in the AB and in the lateral position, and I'm doing a diagram or a triangle, equilateral triangle, to attack the calyx. But nowadays, there is some innovation to use the CT guided puncture in some difficult cases, or there is anatomical abnormalities, and also to detect the surrounding abdominal viscera. And also we have the retrograde endoscopic puncture, which have a special set from Cook, which is called Lawson set. This set, I can puncture the kidney from inside to outside, rather than the normal puncture from outside to inside. This is a case I did in 2018 by this technique of retrograde endoscopic puncture for the kidney, and it is first described in 1983. Nowadays, they are using what is called endoscopic combined intrarenal surgery, that I puncture the kidney, integrate, but I watching by my eye, by a flexi, the puncture when it go in to the targeted calyx, and it has several advantages. That direct visualization to the puncture, I am sure that I choose the right calyx, and also I can take the guide wire through the ureter, which is called the through and through technique, and it makes me save that always I have a guide wire and a safety guide wire in the ureter. And there is also nowadays the navigation. So I can use the CT with a tablet, and I do some navigation to tracking the way of the puncture needle and trying not to injure any adjacent organs. The dilatation of the canal after I did a puncture, we have mainly four ways to dilate the canal, either by the Alcan metal telescopic dilators, or ambulance facial dilators, or single step dilators, and the balloon dilatation. Really, there is no big difference between the two, between the single step and the metal dilators, but they found that the ambulance dilators, there is a recorded pelvic perforation rather than the balloon dilator, but really the telescopic Alcan dilators is very beneficial in cases of recurrent cases, or if I have scars or fibrosis. If I'll speak about the fragmentation, I found that all of us, of course, know the lysoclast, which it is from EMS. The lysoclast is a combined pneumatic and ultrasound. It is a very good machine to fragment and extract the stone in the kidney. Nowadays, we have the holmium laser. The holmium laser gains its popularity that it is flexible, small in size, and also it can fragment all stone. But the problem in the stag stones, I think it will be time consuming. Also, we have the Moses effect, which is innovated by Illuminis, which is preventing the retropulsion of the stone. So it applies a large volume in a less time, but the problem that this machine is still expensive. If we now will talk about the techniques, I think all of us know the standard techniques of the percutaneous, which is now the standard by the European Board of Urology, or the EUA. And it is the first choice if the stone is around 2 centimeters, second choice if it is from 1 to 2 centimeters, and the third line of management if the stone less than 1 centimeter. But the creator of the many Pcnl, they are started to ask themselves why I have to have all this morbidity during the dilatation of the canal if I can do it with a minimal sizes. So they start the era of the many Pcnl, which is starting the sheath from 4.8 up to 20. I think this is an innovation of the Pcnl. It is appeared here. The mini perc, they started in 2001, and the micro perc started in 2011, and the ultra mini perc started in 2013. But the question here, when I will use this many Pcnl, I think the answer is here. If the stones is more than 1 centimeter, if I couldn't do for this patient retrograde intrarenal surgery or ESWL, or there is a failure of this both, and in the pediatric population, I have a lot of advantage for the mini Pcnl, like low morbidity, tubeless procedures, and decrease the risk of damage to the pelvic cell system, reduce the bleeding, and the post-operative urinary drainage is reduced. Also, reduce the need for the analgesia, shorter hospitalization, and better function of the kidney. We can see here a comparison between the sizes of the chassis of the kidney and the bleeding. We found that the larger the sheath of the access to the kidney, the higher incidence of the bleeding, and the smaller size is the less amount of bleeding. If I will talk about the mini PERC, I will find that I am using a sheath starting from 15 up to 19.5. It has a very good advantage that I can use through it a flexible rhinoscopy, and also I can extract the stone, and this is the only one in the mini PERC which I can extract the stones. And there is a comparison between the mini PERC and the flexi. We found that the clearance rate is higher with the mini Pcnl. There is also what is known ultra Pcnl. This ultra Pcnl innovated in 2013, and the sheath, the telescope, it is around 3.3 French, and the sheath is around 11 to 13 French. Also, I can fragment the stone, but I have to fragment it and eradicate it with laser because extraction is slightly difficult. There is a comparison between the retrograde intrarenal surgery and the ultra mini Pcnl. We found that the operation time is less, hospitalization is less, and even the cost is less, and we found that the stone-free rate is higher. The last issue in the
yeah, it's your past time.
Okay.
So please try to
2 minutes.
summarize. Yes.
2 minutes. The third issue is about the microberg. Microberg, it is the first. It was in 2010, and it is the first time appeared in the annual meeting of the American Urological Association. They used a telescope of 3 French, and it is not a cheese. It is a micro-optical needle. Through this needle, I can use what I am using, like what we see here. The needle, there is a fiber optic lens inside. I can use laser, and there is also an irrigation. In this way, there is a comparison here between the 3 ways, the mini BERC, ultra mini, and micro BERC. Really, you will find that the cost of them really is the same. All of them are reusable, and all of them are much, much less if I will use the retrograde intrarenal surgery. This is a table showing that the differences between the 3 by the sizes of the sheaths and the way of extraction of the stone. We'll found that in the mini BERC only I can extract the stone, but in the other ultra and micro I have to eradicate it with laser. So I have some disadvantage for the mini BERC: the longer operation time, high pressure in the pelvis, limited resolution. I have to complete dust the stone, and lack of drainage, and also still the equipments are still expensive, and the learning curve is high. The last issue about the exit strategy. So traditionally, I was having to have a nephrostomy after I finish my procedure for tamponading or for the second session, or to have a urinary drainage. But in some situation, this is when I will use a nephrostomy, if I have a single kidney, if I have a residual fragment, if I will do second look, if I have bleeding, extravasation. This is when I will use nephrostomy. But also I can do a tubeless or totally tubeless. Tubeless, this is mean I will not put a nephrostomy, but I will have a stent. Totally tubeless, this is mean that I will not use a stent, or if, either I will put a nephrostomy. And this have some advantages, like decrease the pain, the hospital stay, and the quicker return to the normal life. Instead of nephrostomy, they are thinking to put what is called hemostatic agents, but there is no improvement in the complication, and it is high coast, and maybe it produce some obstruction to the pelvic cell system. And the last issue, when I can do the maximum stone clearance, I have to do preoperative CT. I can use the flexible nephroscopy. The most important, I can use more than one modality to fragment the stone. So in the next 5 years to 10 years, I think there will be 3D planning, including 3D modality and navigation. I will use the tablet with our puncture for tracking, and the instrument, I think, is a endoscopic combined intrarenal surgery will be the standard in the coming days. So our message after this point, that the Pcnl is the standard for the big renal stones, and the future for the endoscopic combined intrarenal surgery. There is a propagation in the usage of the many PERC, and also it have anyone will use or will do Pcnl, he has to have an effort to completely eradicate the stone. This is the reference for this talk. Thank you very much for your nice hearing to me. Thank you.
Thank you, Dr. Yusuf. Although your first time, but thanks for the wonderful presentation.
Yeah, our next presenter is Dr. Jumbi. He'll be talking about management of urolithiasis in children. And as he prepares to come, we are advised to keep our questions until the next session during case discussion. I think more of the questions can be handled during that time. Thank you.
Good afternoon. Thank you again for this opportunity to present in this conference. My name is Tim Jumbi. I'm a pediatric surgeon based at Kenyatta National Hospital. Now, the topic on the program is management of urolithiasis. But as I was going through our KNH data, I thought of presenting an interesting aspect that I came across, particularly relating to bladder calculi in children. And so I have no conflicts of interest to disclose. And as a form of introduction, bladder stones, they occupy around 5% of the urolithiasis. And this small percentage can actually have very heavy effects on children, especially upper tract deterioration. And so we are seeing bladder stones coming in to these children more and more in our hospitals. And so we thought that it's important to review the epidemiology of these bladder stones as seen in KNH. And so the setting being Kenyatta National Hospital, we did a retrospective review of these patients, and this was a 5-year review. We were able to get around 20 patients. The retrieval method was both electronic and manual retrieval of data. And so when you look at the definition of epidemiology, it's basically the study of disease, its occurrence, and the patterns and distribution of this disease. And so this is what we are going to look at. So the what being bladder stones, the who is really the sex and the age predilection. And when you look at literature, the male to female ratio of bladder stones is usually 10:1. Now the data that we had, all the patients were male patients. All 20 patients were male patients. It is theorized that girls have short non-tortuous ureters And so they are able to pass on the nuclei easily than men. When you look at the age, the literature detects peak incidence of around 3 years of age. Our median age in that data was 5, with a mean age of 4.85. Now, I would take this with a caveat because the average duration of symptoms on these patients was actually 1 year. And I'm going to come to this later. When you look at the when, several papers have tried to put some kind of climatic seasonal variation on the incidence of bladder stones. So when we look between January and February, that's how the graph looks like. Now, the counts are very low. We only had 20 patients. And so it might seem that these patients here in March were many, but you see it's only 4. And whatever is red should be the historical dry months of the year, and whatever is in blue are mainly the wet years of the year. And so you see it's not really following that pattern that was there historically. When you look at the wear, there was some literature in the past suggesting that there is also a Kenyan stone belt, and this stone belt comprises of those areas which are dry lands, mainly lands relating to these areas here and the northeastern province. But when you see our data, most of the patients came from this area. But again, remember, it's Kenyatta National Hospital, and it serves people around that area. So again, this can also be taken with a pinch of salt. When we look at the patterns of presentation, something came here very interestingly. Now, look at you remember I told you that the mean duration of symptoms was 1 year. So I used this 1 year to check how many of these patients presented in less than a year and how many of these patients presented more than a year. And quite interestingly, the patients with hematuria and acute urinary retention are the ones who come early. So the health-seeking behavior is also something that we need to note. These patients who just have lower urinary tract symptoms without hematuria tend to present late, and you can see they occupy 50% of that population. When you look at the pattern of etiology, from the EUA guidelines, they still classify these stones as primary, secondary, and migratory. And you can see that primary stones occupied around 60%, but there's this interesting percentage of secondary bladder stones in children which occupy 35% of that population. And I want to talk more about these particular patients. We only had one patient with migratory stones, and that just means that this stone came from the upper tract. In primary stones, this means that in the absence of other urinary tract pathology, you then form a stone. And from the documentation in literature, these 3 things are the ones which are associated with these particular stones in children. That's the poor nutrition, the poor hydration, and the notorious recurrent diarrhea, which leads to dehydration. So when you look at that graph of wear, it's not necessarily forming in patients which are dry, but you can see places which also have adequate hydration, but the children suffer from diarrheal episodes. So these patients are actually prone to get primary stones. When you look at the secondary stones, these are the ones which happen in the presence of other urinary tract abnormalities. And these are usually the determinants of such abnormalities. Now, in Kenyatta National Hospital, from these 20 patients, 7 of them had secondary bladder stone. And interestingly, 4 of them had VUR, 2 of them had anorectal malformation, and 1 of them had posterior urethral valve. When you look at anorectal malformation as a pathology, particularly the patients who have what we call rectourinary fistulas, they are prone to getting bladder stones. And you can see we recorded 2 of such cases. Now, interestingly, we also recorded these cases after doing the definitive repair. And it looks like literature also suggests that some of these stones occur because of this diverticulum that can be left post-repair. So this is your typical colostogram for patients with anorectal malformation. Whatever you have here, I don't know whether this thing is being seen, but the pointer being seen. Okay. This is the bladder. This is the urethra here. and this is the rectum. And right there is where you have the fistula. Post-repair, this is a patient who has a diverticulum after that repair. And this is a cystoscopic image of the same patient showing the urethra there, and you can see the diverticulum there. So that was going to the recto-urethral fistula. Now these patients have chronic bacteriuria because this fistula is connected to the GIT. So you have bacteria coming in from there. Post-repair, this diverticulum here is notorious for urinary stasis, and it can lead to such stone formation. We had 4 patients with VUR and bladder stones. Now the coded literature of such an association is around 8 to 18%. Now apart from the bacteriuria and the urinary stasis that occurs with VUR, there have also been reports by Madani here, by Mehia here, and they suggest that these patients with VUR also have increased urinary calcium and uric acid excretion. So this might be some of the things that can predispose these patients to bladder stones. We had this patient who was 1 year old coming from Gilkid with acute urinary tract retention and recurrent UTIs. An ultrasound showed bladder wall thickening. It also showed a dilated posterior urethra. And of note is that the ultrasound did not detect the stone. When you did the MCU, you could see a dilated posterior urethra, and you could also see a filling defect. I don't know whether it's clear, but right there is where you have your stone. On cystoscopy, this stone had already moved up to the bladder, so we were able to do the posterior urethral valve ablation and also remove the stone at the same time. Seems that we are not the only ones who have recorded this. There are these 2 papers who have had posterior urethral valves and bladder stones on carrying. So my message is simple in this presentation, that secondary bladder stones, they are common in children. And every time you do an ultrasound and you detect a bladder stone, and this ultrasound shows you upper tract dilatation, watch out for these other things that the child could be having. So they could range all the way from a duplex system of the kidney, ectopic ureters, vesico-ureteric reflux, even ureterocele, posterior urethral valves could also predispose these patients to bladder stones. And so in conclusion, we are seeing that delayed diagnosis occur in these patients who have lower urinary tract without hematuria. That tells us that we need to sensitize most of our parents that some of these presentation are not innocent. The child could actually be having more than just common straining abnormalities in children. When you have secondary bladder stones, please consider KITUI in the presence of upper tract dilatation. And these patients with anorectal malformation should actually be screened for bladder stones, because this is something that might be silent in their bladders and will only come up when sometimes it's too late. Thank you.
Thank you for keeping time, Dr. Jumbi. Now we want to call upon my colleague, Dr. Pondo. Dr. Pondo is a urologist, consultant urologist in Kisumu, practices in Kisumu. He's going to tell us about the optimal imaging modality in Pcnl. Welcome, Dr. Pondo.
Good afternoon, ladies and gentlemen. I would like to extend my thanks to the organizing committee of the conference for allowing me and inviting me to make a presentation on the optimal imaging modalities in Pcnl. This is going to be a talk mainly covering the principles and practical considerations in managing patients with large kidney stones who would qualify for Pcnl. The indications for Pcnl have been discussed, so we are not going to go into the detail. In brief, we are going to discuss the practical radiological considerations in Pcnl. When we collected data during the global Pcnl study in about the year 2009, out of 6,300 Pcnls done globally, 10% were done by radiologists. And so that tells you that percutaneous nephrolithotomy can be considered as an interventional radiological procedure or an interventional urological procedure. But my take is that it should be considered an interventional urological procedure, which simply means that the urologist has to be comfortable with understanding the place of imaging in percutaneous surgery. So the question that we are trying to answer, which I'm going to illustrate with the cases that are going to come, is what is the best imaging modality and protocol to consider when managing a patient with a renal stone by Pcnl? And I mean both modality and protocol, because sometimes we are stuck by saying, yeah, I want a CT scan, but what CT scan protocol and when is that CT scan useful for your consideration? The overall goal from the patient's perspective when we do percutaneous surgery, when we look at patient outcomes, is the efficacy of the treatment, which we assess by looking at the stone-free rate. Doctor, is my kidney stone going to be completely cleared by one surgery? So that is one arm of your preoccupation when you are going to prepare for Pcnl. And the other arm of your consideration is the safety of the surgery for the patient. So when we look at it in all outcomes, we summarize them in efficacy and safety, and the efficacy is considered with stone-free rate and safety is complication rate. So at any time in the process of doing percutaneous surgery, whether it is preoperative, intraoperative, or postoperative, the choice of imaging modality should address these two issues. Is my imaging modality going to help me achieve higher stone-free rates? And is my imaging modality going to confer to the patient a safe surgical journey? So the place of imaging in Pcnl starts from the indication, which means selecting the patient who should undergo Pcnl. And here we are essentially looking at for the patient who has large kidney stones or has factors that are unfavorable for other modalities. In terms of surgical planning, the imaging should help us to know what is the position that is optimal for the patient. Should we do supine Pcnl? Should we do prone Pcnl? Or should we combine different modalities? And the number of accesses that we need to do. Are we going to do a single access or multiple access? That depends on the factors that we are going to outline and the size of the access. You've heard about the ultra mini Pcnls and the standard Pcnls. How does imaging help you? And then the most popular thought is usually about the access. How do we use the various modalities available, ultrasound, fluoroscopy, and CT scans in deciding which one to guide us when we're doing Pcnl. And lastly, in postoperative imaging, we image the patient again back to the first two questions that the patient asked us. Doctor, was it successful in terms of stone-free rate? Was there any complication that you may have not discovered or that you have discovered and you need to manage? So when I think about the place of imaging in Pcnl, it mainly covers the patient journey as illustrated here. The modalities that are available to us include plain abdominal x-rays, which we can pick large stones with. Ultrasound is not an ideal modality for making considerations, but it will tell you whether the system is dilated or if there are obvious stones that can be seen. CTKUB has been the gold standard in imaging, particularly the diagnostic part of it, but more and more people are thinking that it is beyond the stone. It is about the patient and the kidney, and so some people might consider using CT-IVP and, of course, fluoroscopy. Now, attending to the first issue of assessing the indications, I have to type 3 cases of patients that I'm just going to use here to illustrate some of the things that I've alluded to. And the question is, should we consider Pcnl or another modality for treating these patients? So the first case there of a 46-year-old female, this is a patient who was referred to us from the coast. She had had a previous URS for an upper pole stone. So you think about an upper pole stone with a history of previously difficult URS, then you think about a calyceal diverticulum. And indeed, if you look at the CT scan, sorry. Okay, I'll just ignore that. If you look at the CT scan on the left, the patient is on prone, and you can see that there is an anterior calyceal diverticulum stone. We could only illustrate this when we did a CT IVP study. And based on that, although the stone was about 1.1 millimeters, we decided that no, this is a patient that would be a better candidate for percutaneous nephrolithotomy. A similar case of a 33-year-old gentleman who presented with a pyelonephritis picture. The initial CTKUB suggested an upper pole again stone, and then we went ahead and did a JJ stent. But then during fluoroscopy, I'll show you the image on the next slide, we noticed that there was an unusual filling character in the stone. And therefore, we decided to do a Pcnl, and it turned out to be a calyceal diverticulum stone. And the other case of a 46-year-old lady there has a large stagon stone that you can actually visualize on CT, on ultrasound as well. But in brief, if you are to take home any message here, the stone factors that we have to consider: the stone burden, the location of the stone, the Hounsfield units, which gives you an idea of the composition of the stone, the renal factors, whether they are rotations, ectopics, diverticular, cortical thickness, if you want to avoid fistula after Pcnl, all those considerations have to be made. Then the ureter, we often forget the ureter, and you get into trouble a lot. I actually got into one last week. The patient told me, "Doctor, I had ureter implantation in 1993 in KNH for a stone." And actually didn't give it much attention until I had to get access into the kidney. Then you realize a implanted ureter can be difficult to get into. And sometimes you get strictures in the ureters and duplications, and all those things affect which technique you are going to consider. The other part that we often forget about is the extrarenal anatomical considerations, particularly the retrorenal kidney, splenomegaly, perinephric fat thickness, and spinal and skeletal abnormalities. All these things give us trouble when you do Pcnl, and it is important to decipher them early when you're doing imaging. Now, I'm not going to go into the details of this, but this has been well documented before in what we coined the term nephrolithometry, after the people of the renal score came with the nephrometry score. And we tried to summarize all the factors and how they can help you before you do percutaneous surgery. And this is an article that is available in the Journal of Urology. In the interest of time, I'll not go through it. Now, what about planning? Here I illustrate with the figure on the left there. You see the green zone that you can do your access on. The yellow represents the colon, the red represents the vascular structures, and the orange represent the perinephric fat structures. All these things have to be taken into consideration, because the moment you put the patient in your puncture access position, you lose this data. So you have to either have the images with you in theater, or you must have thought before this when you are reviewing the images. The middle image there illustrates a retrorenal colon. Once in a while, you will run into transcolonic puncture. And then the last figure illustrates staghorn stones. Now, in this case, we try to illustrate what a calyceal diverticulum looks like in real life. You start doing the retrograde pyelogram in the image there. You don't see anything. But towards the end, you see a filling space to the upper pole of the kidney. And so this changes your approach. So if you're planning to do URS, you're most likely not going to get into a big calyceal diverticulum, probably the very narrow infundibulum. And the case on the right shows you how much sometimes you have a very small puncture access window. So for this patient, we had to do a CT-guided access because we only had about 18 millimeters of a safe space to puncture, because on the yellow side, you have a retrorenal colon. In front, you have a diverticulum that's just sitting in front of the pancreas. And so the area is a little bit dangerous. And therefore, you choose to do a CT-guided access and actually perform the whole procedure on the CT gantry. And then the last position and place for imaging is to assess the patient after surgery. When do you do the post-Pcnl imaging? Most people, this is a study from the US, most people prefer to do that within the first about 30 days after surgery. And to be honest, most people like to do it before discharge and before removing the nephrostomy, because it allows you to do nephroscopies and also to do stone-free check at the same time. So the patient achieves their two cardinal outcomes at the beginning. Thank you very much.
Thank you, Dr. Pondo, for that stimulating talk and for keeping time also.
Yeah, our last presenter, I don't know whether he's ready. Our last presenter is Dr. Martinez. Dr. Martinez is from University of Barcelona, Department of Urology. He'll be making his presentation via Zoom. So if he's ready, he can go on.
Good afternoon. Do you hear me?
Yes, we can hear you.
Perfect. I will share my screen. I hope you see it properly.
Not yet.
Not yet.
Okay. Do you see it now?
Not yet. Yes, now we can see.
Mm-hmm. Okay, perfect. So those are my slides. First of all, I would like to say thank you to the organizer and also to the Kenyan Association of Urology and also to Debbie Kerr to give me the opportunity to participate in this talk. I will try to talk about new aspects in the medical treatment of kidney stone. This is a really important aspect because nowadays we have, during the talk we have already heard, we have seen that we have new laser, new flexible scope, new technologies in order to make the surgery for kidney stone more safe and more efficient. But the prevalence of this disease is increasing every decade. So we have a disease that we are treating better in a surgical way, but probably we are not treating better in a medical way. And it is not only a border disease, it is also a really dangerous disease. We already know that patients with recurrent kidney stones, they have an increase in the risk of end-stage renal disease, so they can have a reduce in their life expectancy. We will start with the first sentence in the recommendation for the medical treatment by the European guidelines, and they say that the perfect drug for the treatment of kidney stone should be an efficient treatment with no side effects and easy to be administered. Because the main problem with this kind of treatment is the compliance, because most of our patients has different problems to achieve the compliance, but in different studies we have seen that one of the main problems to achieve the compliance is the multi-pharmacy. I mean the number of drugs we have to use in order to prevent a new episode of kidney stone. So the first message should be that we should find a simple treatment for this disease. This is the different steps proposed by Can for the development of this disease, for the development of a stone, and we can resume it in 4 aspects: the concentration of some substances, the modification in urinary pH, the concentration also of inhibitors, and also a 4th aspect, not well known, but we are developing more knowledge about this aspect, about the oxidative stress linked to the metabolic syndrome. So we should focus the treatment in those 4 steps. We have different type of stones. We can divide in 4 main type of stones, and these 4 main kind of stone we can divide into 2 types: calcium stone and non-calcium stone. and the main stone are calcium stones. So we will focus and we will start the talk about calcium stone. And the main aspect we can find in the urine of the patient with calcium stone is hypercalciuria, hyperoxaluria, hyperuricosuria, which is an increase of the concentration of those components that is increase the risk of kidney stone. And also we can find a decrease in citrate and magnesium, which increase the risk also of calcium stones. So the main target we have to achieve in order to reduce the risk of this disease is reduce this concentration or increase the concentration of inhibitors. And this is the European Association of Urology algorithm. Focus on concentration aspects. When we have hypercalciuria, they propose to use hydrochlorothiazide. If we have hyperoxaluria, they propose to use pyridoxine, and if we have hyperoxaluria, they propose to use halopurinol. But we will focus in the main treatment we can use, because as we have seen, then the main alteration we can find in the urine of patient with kidney stone is hypercalciuria. The recommendation is to use hydrochlorothiazide, but we have to keep in mind that there is a risk of hypercalcemia, that there is a risk when you use this drug in patients with hypercalcemia, because we could increase this hypercalcemia. So we should use hydrochlorothiazide in those patients with hypercalciuria, but with no hypercalcemia. And also we have the risk of increase the hypokalemia of those patients when we treat with hydrochlorothiazide, or the risk linked to the glucose intolerance. So it is a good idea to use hydrochlorothiazide with amiloride in order to reduce this risk of hypokalemia and glucose intolerance. As we have already said, in patients with primary hyperoxaluria, which is not a very frequent disease we will find in our office, we should use pyridoxine in order to reduce the endogenous production of oxalate. And what about inhibitors? Also in the algorithm of the European Association of Urology, they recommend when we find hypocitraturia or hypomagnesuria to use alkaline citrate or magnesium in order to correct those parameters. What can we say about potassium citrate? If we want to use potassium citrate, but only by a diet modification, we should recommend 1.5 liters of orange juice in order to achieve the same dose that we achieve with pharmacological supplement. So it's really difficult to increase the deficit of citrate only by diet modification. And also we have to keep in mind that since 20 years ago, it has been demonstrated that the association of potassium citrate with magnesium, it will increase this inhibitor effect, and also it's the best treatment for those patients which has inflammatory bowel disease, because they usually has hypocitraturia, hypomagnesuria, and hyperoxaluria. So this combination of the potassium magnesium citrate will be the perfect treatment for this type of patient. And nowadays we have new inhibitors for calcium phosphate and calcium oxalate stones like phytate. Phytate, it has been shown as a strong inhibitor for calcium oxalate stone in vitro. And also we have seen that if we increase the phytate in our diet, it will increase the phytate concentration in our urine. And there is a link between a lower risk of kidney stone in high or enriched diet with phytate. So phytate seemed to be a good inhibitor in order to reduce the risk of this type of stones. And what about non-Canfion stone? We will focus in infection stones and uric acid stones. In this type of stones, the urinary pH will be really important. Why? Because we know that if we reduce the urinary pH below 7.5, there won't be a production of struvite stones. And we can reduce it using methionine or using acetohydroxamic acid in order to block the ureasa enzyme of different bacteria. On the other hand, in uric acid stones, if we increase the urinary pH of those patients, we can prevent and even we can dissolve these stones if we achieve urinary pH over 6.7, 6.2 in order to prevent this kind of stones, or we can also dissolve them if we increase the urinary pH over 6.5 with potassium citrate or bicarbonate. But how can we control the urinary pH of our patient? Nowadays, we have evidence enough to say that these tips are not precise enough in order to control the urinary pH. So all our patients in which we want to modify the urinary pH, mainly in uric acid patient, we should recommend to use an electronic pH meter in order to check the urine and to adapt the dose of the treatment to achieve the correct target of urinary pH. And also we have some evidence that in other disease, when we empower the patient, when we teach the patient how to control their disease, it also increases the compliance of this treatment, which is one of the most difficult aspects of the treatment for patients with kidney stone, because it's a chronic treatment. So most of the time they stop the treatment after 1 or 2 years. And we also have new aspects in inhibitors for uric acid stone. Up to our knowledge, we didn't have any inhibitors of uric acid stone. And we have those nice studies from Dr. Grasses from Baleares University. And he discovered that with theobromine, which is a xanthine alkaloid with no effects on central nervous system, it's an alkaloid like caffeine, but a xanthine alkaloid like caffeine, but with no effect on central nervous system. They found that with this inhibitor, it decreased the risk of uric acid crystallization. So it's acts as an inhibitor, and it has a synergistic effect with the increase of urinary pH. So probably with the use of this inhibitor, we can also reduce the amount of drug we have to use in order to increase the urinary pH in our patient with uric acid stones. And what about the last aspect? We have already said that we don't have enough knowledge, but we are now starting to know how to change it in order to reduce the risk of kidney stone. Well, nowadays we know that antioxidant can reduce the risk of papillar kidney stones. And polyphenols have been shown in rats, in lab, that can prevent the papillary calcium oxalate monohydrate formation in this time of rats which were fed with polyphenols. So it seems to be an important reducer in the risk of calcium oxalate monohydrate papillary calculi. So if we focus the treatment in those 4 aspects, we have the traditional treatment in order to reduce concentration with thiazide, halopurinol, or pyridoxine. We can modify urinary pH with citrate. It seems to be the best way to do it with potassium magnesium citrate, or we can increase it with methionine. And we also have inhibitor like potassium magnesium citrate, which is also an inhibitor of calcium oxalate and calcium phosphate stones. But we have new treatment, like we have already seen. With phytate and theobromine, we can inhibit calcium or uric acid stones. We can control better the urinary pH with electronic measurements that we have already in the market. And probably with polyphenols, we can reduce the oxidative stress that causes the calcium oxalate monohydrate papillary stones. So we can conclude that the prevalence of kidney stone is increasing in the last decade. Phytates seems to be a strong inhibitor of calcium oxalate crystal, so it can be used in order to reduce the incidence of this disease. We can adjust better the treatment of uric acid stones with a digital or electronic pH meter. With theobromine, we can also prevent the recurrence of uric acid stones, and with polyphenols, it seems that we can decrease the risk of calcium oxalate stone due to their antioxidant activity. This is my talk. And Devika asked me if I can introduce you their products. They have developed products focused on those aspects I have already told. And the target of the treatment of patients with kidney stone for Devika is not only the urinary pH, which can be the first step in order to stop the development of a kidney stone. They also try to modify the composition of the urine in order to reduce the risk of kidney stones. That's why they have divided kidney stones in different groups in order to use one type of treatment or another. And in these slides, you can see that for the main type of calcium stone, we can use lead control pH balance, which we will see its composition. For uric acid stones, we will use lead control pH up, and for infective stone, we will use lead control pH down. What can we find in lead control pH up? We will find that it has potassium citrate and magnesium citrate in order to increase urinary pH, but also it has this new inhibitor of uric acid stones that can reduce the recurrence of this type of stones. And probably we can also reduce the amount of pills we have to use due to its synergistic effect between theobromine and citrate. For patients with infective stone, we can use lead control pH down because it has methionine in order to reduce urinary pH in order to maintain this urinary pH above 6.2 in those patients with risk of infective stone. Also, it has phytate in order to reduce the risk of this type of infective stone, which mainly create calcium phosphate stone but are linked to infective stone. And for those patients which has calcium stone, calcium oxalate, or even calcium phosphate stone, and we don't want to modify the urinary pH, we can use pH balance, which has phytate. As we have already seen, phytate is a potent inhibitor of calcium stones, and also it has polyphenols that can also control the oxidative stress and reduce the calcification of the papilla of the kidney. So those are the products they asked me to introduce you, and that's the end of my talk. Thank you very much.
Thank you very much, Dr. Martinez. Maybe before you sign out, we can allow one or two questions or comments from the audience to you.
Okay, I'll be here.
Any question? Any comment?
Anybody with a question? A
Yeah.
burning question?
Dr. Martinez, thank you for your talk on this subject. Do you imply that this treatment is for asymptomatic stones, or is it for prophylaxis, or is it for stone treatment after definitive surgical treatment?
I believe that, for example, for uric acid stones, we can dissolve those type of stones, because mainly the main reason of this type of stone is the urinary pH. So we can treat the patient just increasing the urinary pH, and probably we don't have to increase so much if we not only use potassium citrate or potassium magnesium citrate in order to increase the urinary pH, if we combine it with theobromine. So we will be treating this type of stone. And also using this type of drugs in order to increase the urinary pH, we can also stop the recurrence of this type of stones. We also know that 50% of the patient that has suffered acute chronic colic pain due to a stone will suffer a second one in the next 10 years. The main problem is that we don't know by the first episode which patient will recurrence more frequently than other. So the target of treatment should be for recurrent stone formers. That's for sure, in order to prevent new episodes. But the first question that asked to any doctor from a patient is how can I avoid to have a new stone? So I believe that almost one metabolic study should be performed to every patient who suffer a kidney stone, and with this metabolic study, we should target our treatment for sure.
Thank you to all the presenters. My name is Dr. Muigai. Now, I have two questions. One is to Dr. Mukua. That was an excellent presentation. My question is, you said the success rate as seen was better for consultants and the registrars. Well, I'm not refuting. What was your measure of success in these patients? What were you using to measure the success rate of your stone clearance?
Can we hold on that question? Dr. Mukua will answer during the next session on case discussion. I wanted us to ask question to Dr. Martinez before he signs off.
Oh yeah, I also had a question to him as well. And my question was, when you're starting, when you're initiating medical therapy, do you have to ensure that you have cleared the stones? And if so, what are you using to make sure that you have cleared those stones before you have initiated stone clearance, and when do you adjust that medical therapy?
Dr. Martinez, are you still there?
Yeah, do you hear me?
Yes.
You can start the medical treatment at any moment of the disease. What you can or you shouldn't do is to perform the metabolic study when you have an acute colic pain or after an acute colic pain, the first month after this episode or the first month after a surgery. In fact, if I make a surgical treatment of an infective stone, of a struvite stone, I'm really fun in order to use methionine and urease inhibitor the first 3 months after the surgery, or even the first 6 months after the surgery, because of the high risk of recurrence of this type of stone. So it depends on the type of stones, but for example, for infective stone, I believe it's really important to start the treatment after the surgery. For uric acid stone, it's also important because if you have left some pieces of stones, you can dissolve them. You can use chemolysis in order to reduce or even to make them disappear. And after the surgery, it's important also to avoid a new recurrence. So, and also if we perform a minimal invasive surgery like flexible retroscopy, in which you leave a kind of sand inside the kidney, it's a good moment to start medical treatment in order to reduce to have a new stone over this sand you have still in the kidney. And I think that the best time in order to check the stone-free rate after any type of surgery is with a CT scan between 3 or even 6 months after the surgery. Because with minimally invasive surgeries like flexible stones, we know that we increase the stone-free rate if we do the image technique after 3 months of the surgery.
One last question.
Thank you, Dr. Martinez. How long do you give your treatment? Is it for the 10 years during which stones are supposed to recur, or what? And then my next question is...
If it is a... Sorry.
My next question is, in your practice at the hospital clinic in Barcelona, have you noticed a drastic reduction in your work as a result of using these medications?
In uric acid stones, for sure. I mean, a patient, we know 90% of the patient with uric acid stone, they have a problem with the urinary pH. And if we don't change the urinary pH, we are not doing medicine. We are just being surgeon, where we are removing a stone, but we are not treating the patient. If you increase the urinary pH of this patient, of a patient with uric acid stone, he won't have a kidney stone no more, that's for sure. So he should keep her or his urinary pH up over 6.2 in order to reduce the recurrence of this type of stone. If you are treating an infective stone, we have also seen that if you have matrix stones, if you use methionine and you perform a CT scan after three months using methionines, you can dissolve also this matrix, which will have become a stone. So it can reduce also the impact in surgery. And with TSI, it's not me, it's the Cochrane review that says that you can reduce 60% the recurrence of kidney stones. So it seems that medical treatment can reduce the incidence of this disease. And that's why it's so important, the first paper I saw from the Canadian Association of Urology, that one of the main problems and why patients are not using medical treatment is because doctors, we don't believe in the result of this treatment, and that's why also patients don't believe in the result of this treatment. Probably we won't cure a lot of patients, but we can reduce recurrence and we can reduce the number of surgeries they have to undergo.
Thank you very much. Okay, one more question.
Just last question, last question, Dr. Martinez. In the absence of metabolic evaluation, which we hardly do in our setup, how would you guess what sort of treatment to give? In the absence of a metabolic evaluation, we hardly do it ourselves.
If you have the opportunity to perform a CT scan, if you can measure Hansfield unit, and if you know that the stone is less than 500 Hansfield unit, there is a very, very high probability of have a uric acid stone. So if you can just perform this CT scan or a plain X-ray and a urinary pH, but a single urinary pH, and you have a urinary pH of 5, and you can see the stone in the plain X-ray or the CT scan has less than 500 above 500 Hansfield unit, you can start urinary alkalinization in order to see if you can reduce this type of stone, because it could be a uric acid stone. If you have, for example, an stone and you have a urine culture and you have a Proteus, a Klebsiella, Pseudomonas, probably it will be linked to an infective stone, and it will be struvite stone. And if the urinary pH is close to 7 or 7.5, for sure it will be an infectious stone. So after the surgery, because this stone you have to remove by a surgery, it will be a good idea in order to use methionine between 3 to 6 months after the surgery, in order to reduce the risk of recurrence and also antibiotic. So you have other aspects or other parameters, not only the 24 hours urine, in order to try to guess which type of stone are you addressing.
Thank you very much. Thank you for making time to speak to us. And I think that brings us to the end of this session. Thank you.
Yeah. Thank you very much.
Thank you.
Thank you very much, Charles, for conducting that session well. We continue with our session on urolithiasis. It has been difficult to stay awake, bearing in mind the heavy lunch and the heat, but I'm told those with specs have had more difficulty. I don't want to mention. But I'll call upon the panelists, Dr. Pondo, Dr. Chavda. The next session is supposed to be a very interactive session. So we are going to have 3 case presentations. One is going to be conducted by Dr. Abdallah and myself, case number 1. Then case number 2 is going to be conducted by Dr. Jeremiah Njogu and myself, and third by Dr. Chavda. Maurice? I did? So we are going to be discussing live cases, and whatever questions you had during the presentations this afternoon, you'll actually be able to ask them at this time. Dr. Abdallah?
Good afternoon. So we can continue. My name is Dr. Abdallah. I'm a third year M.Med Urology in University of Nairobi. So together with Dr. Ikol, we are going to take you through the first case presentation. So the patient's name is, these are initials, M.A. She's 5 years old. She's a female from Wajir, Central. So she presented to us in August, mid-August last year, with a history of bilateral flank pains that had been there for around 2 years. She also had a history of dysuria, frequency and intermittent fevers. She also had a few episodes of hematuria, and she had had several treatments for urinary tract infections on more than one occasion. Due to the persistence of these symptoms, imaging was performed, which we shall see in the later slide. Her basic investigations were done, and they were normal.
Thank you very much. Bearing in mind this history, Dr. Morris Wambani, what is your preferred imaging modality for this particular patient, a 5-year-old with recurrent UTI or persistent pain, who has had antibiotic treatment for UTIs for a long time?
Sorry, the KUB ultrasound in this 2-year-old.
Okay, thank you very much. And what probably will you be looking at in this KUB ultrasound?
I will be looking at both the lower tract and the upper tract. I was looking for evidence of blood outlet obstruction, whether it's hydronephrosis, whether there's any congenital kidney disease, congenital renal abnormalities. Those are things that would really be looking for in this patient.
Any other panelists, anything else you'd want to do?
I think because you have mentioned that the urea electrolyte and creatinine were normal, this is a patient then I would like to do a CT-IVP for one reason. Number one is, of course, there's the stone factors, I mean, for management, stone factors, renal factors, vascular, and all that, so that you can now devise a way or the method of intervention for you to be able to give a treatment.
Something else, Dr. Pondo?
If I didn't know that this girl has a potential history of urolithiasis, I would consider doing a micturating cystourethrogram to look for reflux, because in a girl of this age, reflux disease would be one complex that would present with hematuria, dysuria, and recurrent UTIs. So that's one thing I would look at.
Thank you very much, panel. So we went ahead and did a CT-KUB. None of the panelists, I think Dr. I did ask that we do a urogram, but we did a CT-KUB, and if you show us the results, please.
So this is the CT-KUB, which showed, pardon the images, the person who sent us the images didn't get a clear view, but I tried to filter it, and it showed a right proximal calculus measuring 11.2 by 11.2, and a left renal pelvis calculus that measured 1.5 centimeters by 2 centimeters with bilateral hydronephrosis. There was a moderate hydronephrosis.
Thank you very much, Dr. Abdallah. I think, okay, the images have disappeared. But it's good to note that Dr. Wambani had mentioned that we can do, he would first do a urinary tract ultrasound. Now that we know the patient has urinary stone disease, it is good to note that the guidelines do recommend that the primary imaging when you suspect urinary stones, Dr. Jumbi told us about stone belt, is actually to do an ultrasound KUB. And indeed, it is further quoted that the sensitivity in diagnosing stones for an ultrasound KUB would be around 45%, and the specificity would be around 80%. And then within the kidney, within the ureter, we'll have a sensitivity of 45% and a specificity of around 94%. But of course, the recommendation, if you're suspecting urinary stones, is to do a non-contrast CT KUB, whose sensitivity is 93.1% and the specificity of around 96.6%. I don't know, Dr. Chavda, what do you think? What would you do in Mombasa?
I think when the first presentation of the patient is there, I'll still go for an ultrasound first, because when this patient comes to you the first time, I think at a 5-year-old female who's coming from Wajir with recurrent UTIs, a CT KUB would not be your first investigation of choice in terms of imaging modalities. Ultrasound would probably be a way to go, and probably maybe a plain abdominal X-ray. Considering the fact that this patient has had recurrent UTI, I agree with Opondo that probably we need to also do a micturating cystourethrogram. A micturating cystourethrogram would help, because you also want to check for reflux, because young patients, 5-year-old who comes to you in your clinic with recurrent UTIs, you probably have to look at the possibility of a vesico-ureteric reflux.
Thank you very much, Dr. Chavda, so much for imaging. We now have the diagnosis based on CT KUB. Dr. Pondo, how would you proceed with the management of this child, 5 years old, with bilateral large kidney stones?
Yes, for this child, I would actually consider doing a Pcnl for this child, because the child already presents with bilateral hydronephrosis. In my view, access in this child is already facilitated by the presence of hydronephrosis, and you could actually do Pcnl on one side in one session and then consider doing Pcnl on the other side. But on condition that the child is cold, that means they do not have a current episode of a febrile illness.
Thank you very much. Any other opinion?
I think I will largely agree with Dr. Opondo, but for the sake, I mean not just the sake, for discussion, and of course also illustrate the other interventions, with a large dilated pelvis and a stone which is large enough also that you need a stone clearance, and this patient, probably because of age, there's also metabolic. I will offer him also laparoscopic pylolithotomy as an option. And in last year's presentation, that I had shown that actual Pcnl and lap pylolithotomy were equal in, I think, in all the parameters were looked at. But for the one which was upper ureteric, I think we could stage it and put a stent and then come back, I think, when the system is dilated.
Any other opinions?
First of all, I want to go back to the imaging. I'm sorry, we hadn't disposed of that image. The reason that we would like to do an ultrasound first in this child is to avoid radiation in a 2-year child. Usually, in fact, at this point, parents are usually worried about X-rays in children, and even for medical purposes, we try to avoid. And as you have seen, if there is a kidney stone, ultrasound is going to pick it up in 94%. There's 94% positivity, specificity, and 45%. So you're really having a high chance of finding a stone. And in this particular case, the stones are large, there is obstruction, there is hydronephrosis, which could be picked up on an ultrasound. I would only do a CT KUB if I'm now planning to treat. But I would first do a KUB ultrasound and then do a non-contrast CT KUB for planning purpose.
Dr. Chavda, would you consider at any one time shockwave lithotripsy?
Okay, you've not given us how hard the stone is, so we wouldn't know if shockwave lithotripsy would help, because if we know the Hounsfield unit, maybe then we can plan that. However, considering that this stone is 15 by 20 millimeters in a 5-year-old child, that's by and large a very large stone. So in situations like this, even in an adult, a 2-centimeter stone would probably be tackled by a Pcnl. So Pcnl probably would be my first treatment of choice.
Dr. Abdallah, RIRS, would you?
I think it's an option. Sorry.
Thanks, Nicole. I think it's an option. It's definitely an option. It's a debatable issue. You're looking at efficacy versus complications and also clearance of the stone. Of course, with a larger stone, Pcnl has a better clearance. But as far as complication is concerned, I think still there's a role of ureteroscopy, and because of minimal complications. So this case, I wouldn't like also rush into first stage ureteroscopy and laser, because I would expect infection. So probably I'll go for a drainage procedure first, and then do it as a second stage.
Maybe a question. An RIRS in this patient with a very small ureter. I don't know what size scope would you use for a RIRS. A semi-rigid 6.5 probably. The standard flexible scopes that come are 7.5 range, and maybe getting access up the ureter would be difficult. Maybe you probably need to pre-stent the patient, but also in this patient you need a pediatric stent.
Thank you very much for your comments. Maybe we go to the audience by a show of hands. How many would consider if they had to do an SWL? Extracorporeal shockwave? Okay, one. How many would pick Pcnl as their first choice? 1, 2, 3, 4, 5. Pcnl first choice, 5. How many would pick RIRS? 1, 2, 3, 4, okay, 5, okay. Pcnl, RIRS, 5. How many would go for a laparoscopic or open procedure? 1, 2, 3, 4, 5. So you can see we are balanced in what we want to do. We have the proponents for SWL, Pcnl, RIRS, and laparoscopic or open procedures. Dr. Idid, when you look at all the four modalities which have been proposed, how would you compare the stone-free rates?
Okay, even also referring to my last year's that presentation, I think the best was always been the standard where the benchmark was the Pcnl, which are the highest, which of course the Uralithiasis, if the what do you call it, the anatomy is favorable, then because you are scooping all the stones out was also good in stone clearance. I think the lowest will be of course ESWL, second lowest will be the RIS. And this patient, you need multiple intervention. If you do a RAS, multiple interventions, and the patient who have most probably metabolic issues, most probably maybe even anatomic issues. So the top two will be the Pcnl and Uralithiasis or open.
Thank you very much, Dr. Idid. You have mentioned about multiple procedures. Dr. Pondo, Pcnl, one procedure or two procedures?
Just for pragmatism, I think we would do 2 Pcnls, one in each kidney, just to, because this patient has had an infection and for over 2 years probably they are exposed to antibiotics, and there's always the risk of having drug-resistant infections, and you don't want to have 2 kidneys infected and you have sepsis and you don't know how to do source control in the postoperative period. I would also like to mention that that in itself is a contraindication for shockwave lithotripsy. A patient who has had a lot of episodes of infection is at risk of getting a very severe SARS response when we do shockwave lithotripsy. And despite the fact that children get better stone clearance when we do shockwave lithotripsy, already you notice something odd here. Some of these stones are so big, so the ureter of that patient will not be able to drive the peristalsis to remove the stones in the background of a hydronephrotic system, which is probably having a problem with the coordination of expulsion.
Thank you very much for your comments. Any comment from the audience? Yes, Dr. Anthiwa?
My question is, when you're investigating this patient, what were your impressions? Because he's a patient with recurrent UTIs. What were your impressions apart from stones?
I think one of the impressions we had to manage is of a psychoureteric reflux. That's why we had mentioned that we wanted to do an MCU to check, because that can itself give recurrent UTIs. Obviously, you have to rule out abnormalities in other systems, GI systems and all that. But primarily, we are here dealing with urology, so we'll stick to your urological differentials.
Thank you very much, Dr. Kimani.
Thank you. I had to come off. Already this patient is biased, I know, for Pcnl, because one, you have to drain the system, and if you're going to drain the system fast, it's either a percutaneous drainage or an endoscopic drainage. Endoscopic drainage would require you to go under anesthesia and stent, and you're not sure that you're going to succeed anyway in already an infected kidney. So the risks are higher, and therefore already you have established a tract under local anesthesia or under sedation. So Pcnl would be a way to go. But I was thinking, alongside the same lines, the feasibility of ureteroscopy in a 2-month-old. I don't know how.
5 years.
5 years. 5 years. 5 years. Okay. I was also thinking about the issue of ESWL. We know about the issues of stone clearance. We don't have a lot of information from the case in terms of the hardness, the stone to skin distance, and the likes, and therefore it makes it difficult to give it as a consideration. But the multiplicity of procedures and the cost and availability, if you remove the issues of stone clearance rates at the end, is it a worthwhile consideration? The only issue I have, I don't know whether there are long-term studies to look at the parenchyma of the growing child after ESWL. I've never seen the long-term effects of ESWL on the renal parenchyma.
Thank you very much, Dr. Kimani, for your comments. Any other comments? Yes, Dr. Yeko?
I think in discussing this case, we should have been told the basics. What was the HB, what was the white blood cell count, what was the urinalysis, culture sensitivity. Those are basics which should have come first before we go to imaging.
It was mentioned all normal. All normal. Dr. Ernest Kimani?
When you go to do the Pcnl and then your first puncture, you find a pus coming out from the kidney, what would be your next approach?
Okay, I think there is a speaker who talked about Pcnl, and there are probably 4 types of Pcnl. Standard, there is the mini puck, the ultra mini puck, and the micro puck. Probably in a 5-year-old child, you'd probably go for the ultra mini puck. Maybe the access is around 11 to 13 French. Now, if you do a puncture and you find pus, you always have the option of leaving a nephrostomy there temporarily until now you've cleared the infection before you can go and do a Pcnl.
Thank you very much. Dr. Morris, when you look at these 4 procedures, what's the comparative morbidity would you advise?
First of all, in management of this case, we regard 2 things which I think Tim mentioned in his presentation. One is efficacy and safety. 1, ESWL. The efficacy is not adequate, and it would not really work in this child. Stone burden is large. Child would have to go very many times, and it would not be efficacious. And if it's not efficacious, definitely it is not safe enough. RIRS is a good modality, yes. Problem is that you are going to commit the ureters to possible problems, and that could be an issue. You are unlikely to remove these stones at one go. 2, you will need to have used a urethral access sheath. First of all, you need to pre-stent this patient, either antegrade or retrograde, and then use urethral access sheath because these are virgin ureters before you go in, and it's unlikely that you're going to finish this in one go. So there can be good efficacy if you get access, but the safety is neither here nor there, because you're dealing with a small child, small ureters. You could go into problems, injure the ureters, get ureter strictures, and later on subject the child to 2 problems. Third, Pcnl is okay. The only thing is that you need skills, and if you don't have skills, you can have efficacy, yes, but if you don't have skills, the safety is in question. So those are things to consider. Regarding open surgery, that is very attractive to people who don't have skills in that area, because you can safely have total stone clearance, and you could also be avoiding problems to the ureter.
From Dr. Ndhiwa's presentation,
Open also needs skills.
You require a lot of skills to be able to perform an open procedure.
I would say you don't need skills, but you don't have problems with equipment, etc., etc.
Yeah, technique.
Of course, you can't open a kidney without skills.
Dr. Ndhiwa?
I have a concern. This is a pediatric patient with bilateral stone. It's a high-risk patient. Has possibility of having other malformations like PUJ, obstructions. Did you rule out those possibilities before deciding on the mode of treatment? Because I believe it's going to influence the mode of management you're going to give to this child.
Thank you for your comment. There were none. Dr. Kibani?
I also have a concern about the left side that had a proximal stone. You don't know how proximal this proximal was. Whether it's accessible by Pcnl or you have to do a pushback. And if it's a pushback, then you have to assume the stone is not impacted, because you have to go through the ureter to try and push it back into the pelvis for you to be able to access it from up. How sure it can be accessible by Pcnl? Which opens then the question of an open procedure for this patient.
I think, let me comment on Dr. the resident. It's true that sometimes actually I've seen when we do laparoscopic pyelothotomies, we do a concomitant pyeloplasty. But in this case, in this patient, because of the disease bilaterality, most probably I don't think there will be have been a PUJ obstruction.
Okay, sometimes I think you have the advantage of using a flexible nephroscope to go into the upper part of the ureter. That's a possibility that you can have.
Thank you very much. Unfortunately, Dr. Kimani, we can't answer your question because the image was not very clear. The person who took the images for us did not capture very clear images, but I think it was in the renal pelvis, if I remember well. Dr. SNK?
Good debate. Good debate. My only concern is being practical on what we have for Pcnl. Do you have the mini pack? Do you have the smallest possible Pcnl for this kid? And if you're going to be doing with what we have, the standard Pcnl, I don't know. Maybe then you've done much more on this. What is the long-term effect on Pcnl on children, 5-year-old?
Yeah, thank you for that comment. I agree with you that there's always a concern about the long-term morbidities of Pcnl, but Mahesh Desai and colleagues attempted to quantify it by looking at the renograms that was in adults who had undergone Pcnl, and they realized that the change in the renal function after more than 6 months after Pcnl was less than 1% of the renal function. So that 1% may have not even been statistically significant, but you can imagine that that is in an adult. Now in a child who is still growing and has an ability to compensate, then you find that that effect is even much less. Now I tell you that in my own consideration, I would consider the size of the stone and the perioperative risk that Dr. is talking about to decide the size of the access. Because if you do a 24 French sheath, you're going to be able to go into that system and probably just crack the stone. It's a renal, both of them look like the renal pelvic stone. So you crack them into two and pick them out and come out and let the child go back to recovery. They're able to do much better than having a protracted retrograde procedure that, like Dr. Mbani is saying, has much more risk to portend to that child. And remember that this child, unlike an adult, has a very high a priori probability of having future stones. So we will need those ureters in the future. And the kidney is able to compensate fairly well. So you can actually adjust with the current instruments and even just use the sheath of the nephroscope itself. Remember, this child gives us a lot of advantage that the skin to stone distance is small and the kidneys are hypermobile compared to adults. So there's a lot of room to be creative and achieve good stone clearance.
Thank you very much, Dr. Pondo. It has come out very clearly that you go for the procedure which is safest for the patient and where the surgeon is adequately skilled. In this particular case, I see there are more people for RIRS and PCNL. No, PCNL, then RIRS. After discussing with the relatives, they opted for an retrograde procedure. So, Dr. Abdallah, continue.
The image.
Share the screen.
So the patient underwent stenting, DJ stenting prior to the stone retrieval procedure. So this is an X-ray, a KUB X-ray, post the stenting. I don't know if you can see it clearly on this screen, but I think in the other screen and that one, you can see it much better. In the bladder, there seems to be like there is an intertwining of both of those stents.
So like mentioned earlier by Dr. Wambani, if you're going for a retrograde procedure, the system is narrow, so you'd like to aim to stent before retrograde surgery, and that's exactly what was done. Dr. Wambani, how long would you propose that this stent stays before any intervention?
Basically, anything above 2 weeks is good enough, and that time you would also have taken care of the infection that this patient would be having. Anything above 2 weeks is okay, 3, even 4 weeks. I see someone mentioned the stents are intertwining. I don't think they're really intertwining, it's just that the distal stents are superimposed on each other. It's a bit crowded, yes, but that will cause a lot of roots. We're going to discuss about the length of stent next. But what I've said is the distance, the period is anything above 2 weeks is good enough.
Are pediatric surgeons in the house? Is that Dr. Sawa? Yes, Dr. Sawa, how are you? The availability of stents for use in children. What is your experience?
For stone surgeries or for any other procedures?
Any other procedures?
Yes, it is a challenge. We particularly for the very younger ones, we usually have a challenge getting the correct sizes. So it is a problem. Thank you.
Thank you very much. Those are exactly the challenges those who are taking care of this patient encountered. They had a very narrow choice of stent sizes and ended up with those two, the one on the right being a little longer than the one on the left. That's why you see there's a lot of coiling in the bladder. And indeed, like Dr. Wambani mentioned, that is going to lead to a lot of irritation and therefore a lot of lower urinary tract symptoms, which fortunately the child was able to tolerate up to the time when the procedure was done. Dr. Abdal?
So on 16th of August, the patient underwent laser lithotripsy of the right calculus with the subsequent DJ stenting. He also underwent laser lithotripsy of the left renal calculus. Unfortunately, the left renal calculus was not fully lasered, so the procedure was postponed, and then they did the DJ stent on the left side, so for further lasering of that calculus. So the patient was put on antibiotics and analgesics.
Dr. Chavda, would you handle both stones in the same sitting?
No, I think I would stage the procedure. First of all, I'm even considering how would you go up the ureter. In this, would you use a ureteral access sheet? Do we have a size ureteral access sheet that can go up a pediatric ureter? And this is a dilated system bilaterally. You have hydronephrotic kidneys, and if you're not going to use an access sheet and you're going to use fluid up, there's a big chance that you're going to damage the nephrons more and probably cause phoenicial rupture. So yes, doing RIRS is an option, but there are more complications that might arise just because you do the procedure. Because if you're not going to have an access sheet which is draining out the fluid, then you're going to cause increased intrarenal pressure. The other thing is, if it's a large stone and you have an access sheet, it's easy to basket tiny fragments out, but in this case you probably have to dust the stone, and that is a reason why probably I would still think that, in my opinion, a Pcnl, though has more complication rates, would have a better stone clearance than an RIRS. Obviously the left side we did not have a complete stone clearance, so I assume that the stone must be very hard, and probably now you are doing a stage procedure on the left side.
Dr. Aidid?
I think in respect to the question that you asked, this intervention, whether you will have done both sides at the same time or stage, I will agree with what was done, at least, because look at it from the point of view of cost of this patient going many times. So the smallest stone on one side, if you can clear it once and then have the other one, or at least reduce the intervention, then you might clear all your stones by the second. But if you did one and then come back, then you will come back the third time for that side. So I think if the patient was worked up, he was already stented, system was dilated, antibiotics were given, and therefore in respect of cost now and multiple, anesthesia, then I think that I will agree with what was done.
Any comment from the audience? Yes, Chairman?
Just wondering, the people who say that you should stage RIRS between the kidneys, what is your evidence or what is your argument? And then we were just discussing between three of us here, and between three of us we have done a few children's ureters, and we have never found any problem with the caliber of the children's ureters as opposed to that of an adult.
The reason you stage is purely for financial benefit of you as a surgeon, but not for the benefit of the patient. Let's be honest.
Okay, SNK, would you like to counter that? Okay, Abdallah is of a contrary opinion.
No, I think I tend to differ, Matu. What I think sometimes a stage procedure is also valid, because the operative time is sometimes what brings complications, especially if you are there for a longer time. So you are dealing with a high burden, stone burden, and the stone is hard, and especially if you have infection, presence of infection, that even makes it worse. But even just operating time is sometimes what can lead to complications. So I think, to me, it's better to have a safe kind of situation rather than get into complication and then you have to deal with the complication. So I think I still respect a stage procedure, not just for the financial benefit, but I think for the sake of the safety of the patient.
I tend to agree with Abdallah. First of all, the EU guidelines are that if the ureter is virgin, meaning that it has not pre-stented, you should not approach it unstented. You should always stent it. Has nothing to do with financial. It's just that you are safe. If you are going to use a ureteral access sheet on a non-stented ureter, there is very high likelihood of ureteric ischemia. And European guidelines suggest that you actually stent. You do pre-stenting if you are going to use a ureteral access sheet. And this patient, you're definitely going to need ureteral access sheet to avoid injury to the ureter, to avoid intrarenal pressure. So really, pre-stenting is not really financial. It's also in the guidelines. Probably, Professor Mungai, can you give a comment on that?
Yes, a lot of what you're saying is true, but we've all found that when you go to do your retroscopy, if you didn't see it on the CT scan, and sometimes that's what Opondo was talking about, the CTI-VP, and you do not know the caliber of the ureter, you'll have to find it out at operation, and that's why you end up doing stenting if you can't access. But for a lot of patients who have either passed stones in the past, which is what happens to a lot of children, you find what Patrick said, they find the ureter is easily accessible in most children, either because they've had reflux or they've passed stones in the past. So the ureter is not necessarily virgin when you go, because if it's passed a stone in the past, it's not virgin. If it has reflux, it's not virgin. It's a big ureter. And that's why the decision on when to stent and how to stent and with what is done on the table. I don't think this is something you can tell somebody that you will stent or you will not stent this patient. Because even in a wide ureter, if you have traumatized the ureter for whatever reason, you still are advised to stent. So the question of stenting or not stenting is dependent on how the ureter looks like at the end of your procedure, rather than whether it was used or not used before. Even the size of stent that we are going to use. There are patients, believe you me, who do not dilate in 6 weeks. I used to swear that you put a stent 6 weeks, come back, and you remove the stent and do your uretroscopy. Until a patient came, I couldn't access, I stented, said come after 6 weeks. After 6 weeks, my uretroscope still couldn't go up. Then I left it for 3 months. Get out. Thank you.
Professor, if you had a ureteral access sheath, would you go on a little longer?
A uterus access sheath is not a safe thing to use. Remember, sometimes you're better off not using a ureteral access sheath because the damage done by the ureteral access sheath could be worse than having one. If you look at what happens to the ureter after you removed your ureteral access sheath, the ureteral access sheath, and there's lots of papers on this. The likes of Oliver Trexler have written a lot on what's the purpose of the ureteral access sheath. So I would not use a ureteral access sheath if I can go up the ureter easily. I don't know what everybody feels, but that's what I've heard from everybody else elsewhere, that if you're going to use a ureteral access sheath, use it only if it is useful. If you're going to squeeze the sheath so that you can use the scope, take the scope up by itself. It's a better thing to use than to damage the ureter. And there are safety concerns on ureteric access sheaths, especially the type that you find in Nairobi. You have a 10 French ureteral access sheath, and you could have gone up the ureter with an 8 French ureteroscope, and then you're squeezing a 10 French ureteral access sheath, and in the process damaging the ureter. And you may end up reimplanting this ureter, particularly the lower end of the ureter, which very easily gets strictured, and there is no safety out of that. You will have to reimplant that ureter.
Maurice, what do you think? Ureteral access sheath?
Well, ureteral access sheath in a non-stented ureter carries risks, there's definitely, and that's why it is indicated it's really, you really need to pre-stent. But a non-stented ureter, yes, ureteral access sheath is a very dangerous item, whether initially people used to do it with the guide wire outside the sheath, and you know it used to cause tunnels into the ureter. So really, I would still use ureteral access sheath, especially in terms of intrarenal pressure, and probably on that basis. And especially if it's a ureter I have already stented, I would still use it, because it will give me multiple entries into the ureter without really having to struggle, and it will lessen the operating time, which again still impacts on the outcome.
Thank you, Dr. Aidid.
Yeah, I think I will say the ureteral access sheath, I think, is still useful. Number one, I think the stones that we see are also quite large. If there was a small stone, I mean 5 millimeters, 6 millimeters, or something like that, you need once, and then you dust it or you break it into fragments, and you can stent the patient. But if you are going to go in many times, then you reduce the risk of injuring that ureter if you had an access sheath in that one. In this patient, of course, we are discussing this case, which had got a large stone burden and possible infection. So the stent also was put in respect of not only dilation, but also, I think, for decompression.
Thank you very much, I did. Now that you're at it, would you dust and go or perform complete stone retrieval?
Sorry again?
Would you dust and go or perform complete stone retrieval?
Okay, it depends on the size, actually, of the fragment. If, number one, the size of the stone, again, here, was large, so that meaning that if you were to dust, then the whole kidney will just be full of dust, and I don't know how long it will clear. And of course, also will increase the time of operation if you're just dusting. But if you fragment it very quickly and broken into pieces, then you will be also obliged to remove as much as possible to, again, reduce the burden again.
And it would be easier if you have an access sheet.
And it would be easier if you have.
Dr. Pondo, a comment before we go to Dr. Kimani?
Yes, there's one risk that we, of course, the younger urologists among us, we are always at risk of picking dogma in this kind of conference. But I think that we have to learn to be pragmatic for every patient. I agree that it is possible that you can have many passes in a virgin ureter with a ureteroscope and you can get away with it. But there are some few patients that may actually get harm. So when you see, for example, the EAU guidelines say that please pre-stent patients who have hydronephrosis, what that guideline actually doesn't tell you is that all the patients are going to benefit from the stenting. Some of them will benefit. So when we go back to the evidence behind that recommendation, there's usually what we call the numbers needed to treat. So if you do lithotripsy in a child or an adult who has hydronephrosis without stenting them, you have about 7 to 10% of the patients that are at risk of getting a stricture in the future. So it is those 7 patients that we are protecting. Maybe the 60 patients that you have done successfully fall amongst the 80 or the 60 patients who did not need the treatment. Now you go and ask yourself, what pain does it bring to you as a practitioner or to that individual patient who has to come back first for a redo procedure and probably for ureterostomy? So that is the thinking of the guideline makers. They are not very dogmatic. And of course, it comes with the experience, like Prof is saying, that those patients that you can actually recommend and look at it and say, you know what, I think this patient I can go without doing pre-stenting. But something else that can help us a lot is intraoperative retrograde pyelogram. because it gives you a lot of information. Instead of debating in our own heads that was this ureter caliber small or not, maybe the patient has a ureter caliber that is 11 millimeters from the congenital disease that is underlying the stone. We don't need a stent. We can actually go in with a scope. So I believe that every patient needs their own merit when we make consideration. And for the younger one amongst us, there is always a pitfall of picking dogma. I think the principles is what matters in making patient-centered choices when we make decisions.
Dr. Kimani?
Yes, as you consider the advantages that the access sheath may confer in terms of intrarenal pressure, we must also be wary about the urethra, especially if this is a boy child in whom you are keeping that access sheath for, say, 1 hour, 2 hours as you do either of the procedures. If we follow up these patients, especially the boys, majority end up with a stricture. In fact, there's a boy whom we are seeing had a procedure, but he did not have any evidence of a urethra thereafter. Urethra.
Absolutely. Thank you for raising an interesting point, Dr. Kimani. Which one would be worse in terms of predisposing to urethral stricture? Multiple pulses or long contact time? I don't know.
I guess both.
Which would you choose?
Both have their own merits and demerits.
The multiple times is you see it's shorter periods for many occasions. The one time is one longer period. So both, I guess, would be equivalent.
So endourology is not without complications. That's what has come out. Dr. Wahenya, you had a comment?
Yeah, thanks. Just a follow-up on Kimani's comment. I mean, I would think that it's more of ureteric strictures, or you're talking about urethral stricture, Kimani? Urethral stricture. Yeah. That's unheard of even in the literature.
No, they're not really unheard of. They
are very, very, very rare.
They're very rare.
Because very rare. Yeah, what I was thinking that just for the sake of residents, what I wanted to comment is that if we go by the principles of endourology, that you don't use any force at all. And as Opondo has put it rightly, that every case has got its own merit. So when you go in and decide what you want to do, I don't think so there's any dogma as to whether you need to pre-stent the patient or not. But you assess the situation and see the caliber of the ureter. And this is very important for the sake of the students, if you're having difficulty in putting that urethral sheath up, then for sure you're going to have problems. But if it goes in smoothly without using any force, the point here I want to make is don't use any force. You have to have a clear vision in endourology. You don't have to use any force. The moment you are struggling or use any force, then you end up into problems.
Now, yes, I was going to comment on young people vis-a-vis the old people. You will find sometimes a young person does not allow the scope to go past the sphincter. That's the man who's going to develop a membranous urethral stricture. And the more force used, your pre-stenting is not going to affect that, but I'm sure you've all seen times when getting the scope through the sphincter becomes a big challenge for you. That's the patient you've got to be wary of, and that's the patient who does badly with a stent. Because when you leave a stent behind in these patients, they come to you and tell you tomorrow morning, just remove this thing. It is impossible, I can't stay with it. So you have to remove it, your stone is still up, because he can't hold that stent. I don't know whether I'm the only one who sees these patients on whom they can't stay with a stent beyond day 3. You just have to go and remove it. So you're left where you began. I don't know what people do when you find these patients who say, I can't keep a stent. Because we are assuming, and even children, there's some children who can't keep a stent. However short it is, even if you use whatever size, they tell you, the mother comes and tells you, no, he can't, he didn't sleep the whole of last night. So as a doctor, remove this thing of yours. So you end up removing it. What do you do?
Thank you very much. So Dr. Chavda, doing multiple procedures in this child, what would you think is the ideal time to return for a residual stone or residual fragment here?
Okay, it depends on a lot of factors. One, I think I would probably do a full blood count and its kidney profile, and obviously check for urine culture. If there is no infection, I think within 2 to 3 weeks I can still go back and do the second procedure.
Any other opinion? 3 weeks, hands up. 1 week. 2 weeks. 2 weeks. 1, 2, 3, 4, 5, 6, 7. 3 weeks, huh? 4 weeks.
3 weeks.
6 weeks. Okay, guys are not in a hurry to get the money, eh? Dr. Pondo, you're preparing for the second procedure. You know there was a stone fragment. You know you cleared one side, but there's a fragment on the other side. You know. Would you image before the second procedure?
Yes, depending on where we left the previous fragment, because sometimes you go in and the fragment that was in an otherwise compacted proximal ureter, after removing 50% of it, now has migrated back into the kidney. So just for purposes of preparedness, I would re-image. As a matter of principle, more and more I'm believing that I should consider having an image of every stone that I do, preferably with a scan done within a week, ideally on the same day, because you go in there and sometimes you get pleasant surprises. It happens all the time. You go for a stone that you thought was a proximal ureter stone, the next time you find it is completely lost in the kidney, and you have to change your armamentarium.
How many don't think it is not necessary to re-image? Not necessary to re-image?
Yeah,
how many think you must re-image? Okay, so the general consensus is re-image before, know what you're going to do. Maurice, yes?
There are two possibilities. There are two possibilities. The stone could migrate back to the kidney, usually to the lower calyx, pushing more problems. If you are going with semi-rigid, you are stuck, you need a flexi. Two, the stone could actually extrude and have come out. So you really need to re-image patient to be on the safe side. And as Dr. Ponda said, the shortest time to the time of the procedure, the better. Ideally, it should be the same day if you can.
Dr. Kimani?
In the imaging protocols, is it a CT, is it an X-ray plane?
Should be a CT. If you're told
re-imaging, Dr. Pondo, what?
The simple answer for me would be CT. I know you're concerned about the radiation, but you can always customize, you discuss with the radiologist to customize how they do the collimation and get less exposure. But if you want to be more nuanced, you can go back to the original images, check the Hounsfield unit, look at the tomogram, and if the tomogram showed the original stone very well, then you can be a little bit conservative and just do a well-collimated X-ray.
Just to comment on that particular case. When you're attending a patient, there are two things you have to consider. First is patient safety. Radiation is not safe for a patient every now and then. Number two, you are the one who did this stone. You knew the size. You know it can't pass. The question is where it is right now, right? When you're going to do a stone, this is not a cheap procedure. It's expensive. We also want to save the patient a lot of cost or unnecessary imaging and retrograde. I'm sure you have a semi-rigid and you have a flexi. So if you go with the semi-rigid, you don't see the stone, go with the flexi up to the kidney. Save the patient radiation, save the patient money for CT scan. Sometimes guidelines are to assist you, but they're not cast on stone. Thank you.
Waweru, did you have a comment?
I think you didn't tell us you've hidden the Hounsfield unit of this stone, but also 50% of the stone was broken on the left side. So perhaps you're having about 7 millimeter.
Yes, 1 centimeter.
Yeah, 1 centimeter. I think it would be nice to do another CT scan, CT KUB, just to be able to see and also check your side on the right, whether you really clear the stones completely.
Okay, thank you very much. I did. Any comment? Did you have a last one?
No, I think if I must say something, I think I will agree with Matu. And because you were there before, I don't know why you will now need to do another CT scan. And
In
you
3
know
weeks.
what you left behind.
Yes.
Yeah.
And it's only 3 weeks.
And it's only 3 weeks.
Yeah, you were there before, but you are there not now. Before it's totally different.
Okay,
from
Kimani
now.
is itching to say something.
And you are very sure you came out with everything, only for an image to be done 3 weeks later, and there's a 5 millimeters or 7 millimeters stone.
Just to ask, does that mean after doing that second surgery, you will do another imaging again? That will make 3 images.
I think we must differentiate stone clearance and this patient. If you are going to do a stone clearance, then the stone clearance rates, which are in the literature, are about after intervention, and you see how much your intervention was successful. We must differentiate from a patient who has been planned for relook or redo or whatever you will say. So in a patient which I have planned that I'm coming back because I left a stone, I don't think I need to reimage that patient. But for the stone clearance, to convince the patient that you've cleared the stones and all that, it has happened to me what Dr. Kimani is saying, and when I looked at it afterwards, it is coalesced stone. The stones are very small, fragmented and all that, and they coalesced and they look like they're even larger than even the previous stone, which patient have to bring. So I think it brings the idea of, again, do you leave the stent, how long, and all this and that, and then, but that's a different story.
Okay, Dr. Abdallah, let's continue.
Okay. Maybe to add to that, a
Okay,
small comment. Maybe in the event that you don't want to image, and during the first surgery, if you think that you've left a large stone burden, then when you go back in, maybe after 2 to 3 weeks, you can actually perform a retrograde pyelography. Sometimes you find that the fragment you left in the pelvis has migrated into the calyces. So if you go and do a retrograde pyelography while you're going up, then it can actually tell you, give you a guideline on whether the stone is still there in the pelvis or whether it's migrated up into the calyces and which calyx. And that at that point in time, then you can decide whether you're going in with a semi-rigid or a flexible ureteroscope.
Chapter has raised an interesting question about retrograde pyelography. By a show of hands, how many have easy access to retrograde pyelography where they practice? 1, 2, 3, 4, less than 2%. Okay. Okay, less than 2% have access to a retrograde, have easy access to a retrograde pyelogram. In my primary place of work, I really have to work very hard. I actually have to work maybe for 2 days to be able to do a retrograde pyelography on table. Yes, Professor.
Now, I think everybody here practices where I do. And the one thing you discuss with patients is the cost of the procedure. Would you go to do a ureteroscopy without telling him whether you will need to do a flexible ureteroscopy or not? Even an insurance patient, unless the cost of the flexible ureteroscopy for you is not an issue. Because you need to know whether you are going to do retrograde ureteroscopy only and do laser, or you're going to do an additional flexible ureteroscopy, which is going to bring in image intensifier, is going to bring in a flexible ureteroscopy. And if you are going to have that discussion of how much it costs, the not re-imaging is going to bring you a patient who says, I can't afford. And he's not affording after he has been put under GA.
Thank you very much, Maurice. Let's move on.
If I just mentioned, I mean, retrograde pyelography, it's nice to say it, but I'm not very sure how useful your retrograde pyelography is at that stage. You go and do this procedure, and the pyelogram shows that there's no stone, and yet there is a stone. I'm sure a lot of you have done that. You have done retrograde, and it's not showing. Doesn't even tell you.
But Maurice, I think what Matu said, you have both a rigid and flexible ureteroscope.
And most often, even if you have the II machine, it is easier to put in your rigid ureteroscope and see what is happening. If the stone has migrated, there you are.
For me, it's, I would still do a short non-contrast CT. It's a shorter procedure. I would be sure of what I'm going to do. If a stone has passed, I don't do anything. I come out with a stent. If the stone is there, then I plan. But I really don't think it's that easy.
I was just talking in terms of the retrograde pylography. I agreed we need to do a pre-imaging. Thank you very much, Dr. Abdallah. Go ahead.
So 4 weeks later, the patient was taken to surgery for stent removal on the right ureter and also for completion of laser of the other calculus on the left side. So a short stay DJ stent was deployed on the left side, and the parents were educated on how to pull it out. And on the third postoperative day, the stent was pulled out as directed.
By a show of hands, how many use short stay stenting post-URS versus okay, long stay, more than a week? Okay, more use long stay than short stay. Okay, thank you very much. Dr. Morris, stone analysis. Dr. Bin Salman gave us a presentation, no need to do in the first one. The man from Mitishamba, man from Spain, said you do so that you decide which one to give. Would you do stone analysis, and if you are going to do, which one?
In our setup, it's a tall order. The things that you need to do is X-ray diffraction or spectroscopy or chemical analysis. All that's available to us is chemical analysis, which again some facilities don't offer. I think X-ray diffraction, I'm not very sure who does it. I think only Lancet does it, but they send it to South Africa. It's an expensive exercise. That's why I was asking our colleague in Barcelona about that. But usually, of course, we take the stone for chemical analysis. That's all we usually do for the most of us.
Just to add on that one, number one, there are guidelines on who to do stone analysis, bilaterality, stone burden, and I think there are around 4. And in our patient, again, we come back to our patient, is a child. I think all the pediatrics is fair to do stone analysis so that you know that it's most, I would think, is a biochemical kind of. They may not have lived that long to form stones, calcium-based. So it's good, I think, for children. And they come with multiple stones, bilateralities, and even the stone burden is also high. So it's good to do so that you can advise them on the dietary and any other things that you can do.
In your practice, I did. How easy has it been for you to get a stone analysis done, and at what cost?
I should agree with you that, but I think we normally, even when I was in Aachen, we were sending it to either Germany or South Africa. Now it's cheaper with some laboratories coming from India.
Yeah, so it's not easy, especially.
It's not easy.
Yeah, it's not very, very easy to get a complete stone analysis done, and indeed a metabolic risk profile on some of these patients. Wow, some patients get crazy quotations. Kimani?
Yeah, the issue of stone analysis in Kenya, I don't think we should say we have stone analysis, because whatever we were doing was just the chemical studies, which definitely gives us very wrong things. And to say about the guidelines and on stone analysis, the guidelines I looked at were very controversial in all aspects. There's a question of who is driving the guidelines. The guidelines driven by the pathologists advocate for stone analysis, but guidelines driven by the surgeons do not see the value. They actually see the additional cost. And that is why people thought about looking at the basic minimum in terms of workup that should be done, and therefore use it to create more like a uniform prescription for reducing stone burden. And I think that's where most people or most surgeons fall.
Professor?
Now, I happen to have worked in most hospitals in town, and the information you get from the stone analysis is difficult to use to advise patients on what to do, if anything, to prevent future stone formation? At the Nairobi hospital today, you get something about the color of the stone, and that the stone is small, and so the stone was brown. And so I don't know what to tell the patient when their stone was brown. and I think that's the challenge that we have in this country, that the people you're asking to do this analysis do not understand the reason behind the stone analysis. It's not that they couldn't do, maybe they could buy a few equipment, but they are comfortable with telling you it's a brown stone, it is a few millimeters, and leave you with that. And I feel very frustrated because I always want to ask a stone analysis, because if you do not do a stone analysis, so you give the patient to stay with the stone and go and show his relatives, then when he next comes with a stone, you are at where you began last time. And that is why the guidelines advocate sometimes for certain situations you need to do a stone analysis, particularly if you're going to talk about an intrarenal stone. If patient had a kidney stone of whatever size, you need to know that this stone is likely to be formed, has a 10% chance, has a 50% chance, or 100% chance. Or sometimes, especially when you do ureteroscopy without doing analysis, and you've seen a stone in the kidney, and you have fragmented a uric acid stone, and then you tell the patient that they will not form a stone. And then you'll do an X-ray and there will not be a stone, and you'll tell them they are stone-free. I think for that reason, stone analysis is something we need to look at carefully.
Thank you, Dr. Abdallah. Next slide. Let's see. Let us look at that stone analysis report, even though it is briefer than me.
It was done here.
So,
if I may ask Dr. Pondo, do you have access to it? Based on this stone analysis we have, I don't know whether it's clear, probably not. Is there any advice you can give this particular patient with regard to preventing further stone development?
Yeah, so this stone analysis here reports calcium oxalate monohydrate, which is 20%, and uric acid is 10%, and ammonium urate is 70% of the total stone burden. So here, of course, we are going to go by the standard recommendations like our colleague from Barcelona was mentioning. This patient predominantly has a uric acid or a urate stone component, which is up to 80%. The ammonium component, we are not sure whether it could be because of the intercurrent infections that she had. So if you go back to the history of this stone, maybe one would find that initially it was a uric acid or an oxalate stone, and with the recurrent stone formation, it became a mixed stone. So what it tells us in brief is, one, we need to get complete eradication of the stone and then the infection, and then we would go and do pH workup for this child. Now, for children, this is where now we would want to involve the nephrologist, because this child could be having an underlying metabolic acidotic or those type of tubular acidosis kind of situations that could be driving the background of the initial stone formation. So this is, of course, an ideal child to work in a multidisciplinary team with the nephrologist to do workup further to assess the lithogenicity of the child.
Thank you very much for your comment. Any additions? Interesting, the nephrologist said, see, the urologist has removed your stone. It's okay. That's what he says. Further comment?
Maybe in the absence of anyone commenting, I just wanted an opinion from everyone. This patient, you removed the stent, the previous one, and then you went back to remove the second one later on. Of course, I appreciate that the string was left behind so that it can be pulled out. But I wanted to ask, if you had stented both sides and you were to go back on one side and you stented it without the string, is it safer to leave that stent that you had finished with before, so that you have got a longer period to drain that kidney and also to increase your rate of stone clearance on that side, since you know that you will come back to remove the other stent, which you are going to leave now. Any comment?
So what you're asking is whether in the second operation.
Yes. The second operation, instead of removing the stent, if you could leave it longer, because so that you can come, when you're coming back to remove the one you're going to leave now, you remove them at the same time, so that you have got a longer time. Is there maybe, I don't know of any evidence, maybe there is, of you leaving the stent longer so that there's a better stone clearance, just in case. I mean,
but it would
but
longer than 3 days?
I mean,
it's only 3 days more for the one on the right.
Yes.
Because
no, I mean another conventional case. This one I know you already left the string, so there's not a debate. If you knew that you're going to leave the string, then you're just going to pull. You're not going to do cystoscopy. So I'm saying, which one the one which you know that you go back, will you have left that stent?
But there was no going back in the second case after the second operation.
A hypothetical question. I was just asking what would be the opinion.
Or if you suspect you're going back.
What was the reason? What was the reason for 3 days? Why not 1 week or 2 weeks? Why 3 days? Yeah. If you're leaving the stent for 3 days, what made you tell him to remove after 3 days? Why not a week or 2 weeks, or why not at all?
Kimani, your experience with the not stenting?
For 3 days. I mean, why 3 days?
I got one incident where I did bilateral. There are small, very tiny stones, but obstructed at the. They were about 5 millimeters at the distal VUJ, and another one was on the upper ureter, and the patient went into total anuria on day 3, despite having not a single fragment. But I also wanted to make a comment on the issue of the analysis that we had here in terms of this patient has uric acid, is a 5-year-old. Any possibility of those metabolic disorders, Leishmanian and the others? And number 2, if you have an infective stone in this child, because certainly there are components of infection, what's the long-term effects of bilateral reflux with our procedures on the kidney and recurrent infections?
So do you mean bilateral reflux that was de novo or acquired?
Maybe acquired from our procedures.
Yeah, it's very unusual to get bilateral reflux from ureteral instrumentation. If any, there would be more of stenotic lesions. Maybe Prof has seen one, but it's very, very unusual to get reflux disease out of instrumentation, unless there's an injury and you lose the VUJ competence.
Okay, just to wrap it up, Dr. Oloch.
Yeah, my question is, was the patient considered for tamsulosin and antibiotics just because of the stenting?
At what stage?
When the patient had bilateral stents and there is no infections, will you consider that such patients for antibiotics prophylaxis?
I'm not aware of literature for prophylactic antibiotics for stent. Number 1, you put them on a steroid. I mean, unless the system was infected. That's one, of which patient will go for treatment, not just prophylaxis. But in the absence of that, then you know, number 1, the stone will stay shorter, and it's for drainage. And I think it was sterile as well when you are putting it. I mean, so I'm not aware of any guideline or anything that will say that you put antibiotics, prophylactic antibiotics.
Anybody, by show of hands, who gives antibiotic prophylaxis for stents?
Okay.
How many weeks? 6 weeks?
5 days, 1 week.
5 days. Oh, look, you are talking about the 5 days or throughout the stent duration?
Yeah.
Throughout the stent duration.
Yeah, because the one of Prof is talking now is different. Because you are treating from the time of the surgery, time on the injuries.
Yes.
But not prophylaxis for the stent. Yeah,
Maybe I can say something. I had a discussion on use of antibiotics and alpha blockers after stenting. And if you look at the guidelines, if the patient had a sterile urine, there is no indication of prophylactic antibiotic other than the only indication is the one-shot prophylactic antibiotic you give in theater. There is no indication for prolonged antibiotic after the stenting. The only indication for prolonged antibiotics is for patients who are diabetics and patients with chronic kidney disease. Use of alpha blockers and the antimuscarinics. There's a questionnaire that was developed for stent symptom questionnaire. Not every patient develops symptoms after a stent. So using that questionnaire, if a patient has loads or pain after stent, those are the patients who will benefit from the alpha blockers and muscarinics. Now my question, Chair, if you can allow me, I'll ask either upon or I did. In this patient, we were told that the global renal functions were normal. Is a patient that we did a RIRS, and it's a patient with bilateral hydronephrosis. The grade, I'm not sure if it was shown. Would you consider doing a renogram to find out the split renal function, because you need a normal GFR for stone clearance when you do RIRS? And patients with hydronephrotics are likely going to have some derangement in their split renal function.
I think one thing that you mentioned is the obstructed system. And I don't know how sensitive is renograms in an obstructed system, because I have seen people do that to justify nephrectomies, simple nephrectomies. But I always think, in my opinion, that an obstructed system most probably, that's why we always used to say delayed excretion, because it's obstructed. So the same, I don't think you can use that one later on, I mean, as a clinical judgment to do an intervention. But if that patient was decompressed, let's say that you have done a stent, and now the systems are not blocked, then you can do whether there's a renogram, the DMSA, just to see whether there's a scarring or something like that, rather than just the function. I would think so.
Maybe can I comment?
Sorry.
Even if you do a DTPA renogram and you find that the split function is abnormal, would that change your management if it's an obstructive stone? Because that obstructive stone might damage the kidney more. So at the end of the day, if it's an obstructive calculus, would it change your management even if the DTPA renogram has abnormal split function? Probably the question here we should ask is it going to make a difference in the management of that patient?
The renogram I'm doing is not for obstruction. It's to find out the GFR of this patient. Because if a kidney has a GFR of 20 and is obstructed, if you do an IRS, you definitely are not going to achieve your stone-free rate, because while the urine comes from to clear the fragments. So the renogram is not for find out if it's obstructed or not, but basically to determine the GFR of this patient.
Thank you, Dr. Pondo.
Yeah, I think that's an excellent equation. Look, you'd need to have increased GFR around the time of doing the IRS to improve the clearance. But one surrogate that you can use is the CT scan. You just look and map the volume of the parenchymal loss. And if you see that the parenchymal loss, if you could map them and draw and just look at the surface area, you get an idea of what the split function is likely to be. And that saves you the cost of doing the renogram studies. Because in the setting of obstruction, you are going to have false negatives, because you are going to get the GFR on that kidney that is obstructed that is going to be lower, simply because the hydrostatic pressure on the efferent side is higher. So if you have a high efferent, you can't judge the patient. Maybe the split function there would have been, say, 30%, but the true function, once you release the obstruction, will come back to 45%. So if you really want to know what the function of that kidney is, you can use a surrogate, which is a CT scan of the volume of nephrons that are there.
Ultrasound, just to see that there's flesh.
Yeah. Thank you very much for your comments. And indeed, the renal function will, you need to decide beforehand whether you are going to do dust and go or complete stone removal. So if you have a little bit compromise in renal function, then you want to avoid the dust and go, but rather do complete stone retrieval. Dr. Chavda, we are talking about stone-free rates. What's your comment on re-imaging after definitive stone treatment? When and what?
Okay, in my practice, I usually don't send a patient for re-imaging unless I have doubt that I've left a fragment behind. Another reason I would re-image a patient would be that he becomes symptomatic, maybe in a couple of weeks, or he becomes symptomatic, then I'll probably do re-imaging, but not as a routine.
Any other thoughts?
For academic purposes, in universities, probably in IACI, we will be able to do that. But for cost and for the patient, I think to do that just to see that you have cleared your stone, I think maybe you don't have.
How many would re-image after complete stone retrieval? Okay, one. How many would not routinely re-image? How many will tailor it to the patient? Okay. Middle ground. So thank you very much. Thank you very much, panelists, for the interesting discussion. But maybe before we conclude, let me ask, looking at this patient's management, are you happy, or would we have done something different? Let's start from the extreme end of Pondo. Don't say I'm not happy you didn't do a Pcnl.
No, I'm actually happy for the patient because that is the essence of pragmatic practice, that you solve the patient's problems with the tools that are available. So as long as we achieve that, then we should be happy, I think. Because you'll be surprised, so many things that we do here, somebody elsewhere might think, yo, that is a cake. But what matters is safety and efficacy.
Any other comment? Professor, were you marking us?
I wanted to say something.
I wasn't marking you, but I think this child was fairly well managed with the resources available. And that you were able to achieve a complete stone clearance was an indication of the planning that went into the management of this child. And we were left with a safe child. And having seen the stone analysis, we are lucky that we didn't even get sepsis, which is why I was talking about the prophylactic antibiotics. Wait till you have done a uretroscopy and your patient has sepsis and goes to ICU on day 3, and you see what the relatives think of you. They don't know that you don't determine what happens. So I think this was a well-managed, and it's typical of what is expected of a third world, poorly resourced hospital. In terms of, I could see that this was driven by the urologist. The radiology probably would only come at this time and this other time. We have challenges of getting radiology support at certain hours. We have challenges of getting radiology support of good quality to make decisions on. And you've seen and I don't want to mention names, there are times when you're told you can see a stone on the CT scan and you see only contrast and you don't know whether there is a stone or there isn't. And you have seen situations when you've been told there is a ureteric stone at the lower, and then you see 2 dots, and the 2 dots correspond to the ureters, which is the contrast that was flowing through those ureters. And sometimes, maybe it's financially good for you to scope those patients and tell them there wasn't a stone. But I think this is one support that we are very lacking. DPTA is 34,000, I believe, at the Aga Khan Hospital. So comparing a CT scan to DPTA, you see a big difference. And it is the only service available, and it takes 2 weeks to get a DPTA or even a bone scan. So DPTA may not be available for most of your patients, Carol, not because you wouldn't want to do it, but it's not going to be available. It might be a useful tool for future reference for this child to find out what kind of renal function they had. But I think what was used here is the pragmatic approach, and that you even put a stent that could be removed after 3 days was very kind to this child, that they didn't have to go to theater again in a poor resource setting. So my judgment, if I could, Dr. Icol, is that the team that did this did better than average. Thank you.
Thank you very much. So with those remarks, I think we are going to close the discussion. Did you have something very pressing?
No, let me
So thank you very much. With those remarks, we are going to close the discussion. It has been a very interesting case. We had 2 other cases, but in the interest of time, we are not going to discuss them. We'll probably discuss them in our grand round, CME, urology, which we hope we are going to kick off. Panelists, thank you very much for educating us. Audience, thank you very much for your participation. The Kenya Association of Urological Surgeons Organizing Committee has organized for you something. I don't know whether the chairman would like to invite you officially, or he wants me to invite you on his behalf. We have organized some cocktails for you after this. Please, if you go to the exhibition area, we'll be able to share some cocktails. Thank you very much for your attention.